जनरेटर तो लैपटॉप लेना चाहिए।
ಎಲ್ಲಿ ಕೂರಿಸ್ತಾ ಇನ್ನೂ ಇಲ್ಲ ಸರ್ ಮಾಡ್ತಾ ಹಿಂಗೆ ತಿರ್ಗಿಸ್ಬೇಮ ಅದು ತಗೊಳ್ಳಿ ಇದು ಕೇಬಲ್ ಹಾಕ್ಬೇಕಲ್ಲ ಆನಂದಣ್ಣ ಇದು ಕೇಬಲ್ ಲಾಂಗ್ ಕೇಬಲ್ ಫಸ್ಟ್ ಖಾಲಿ ಇದೆ ಸರ್. ಮಾಡಿ ಇದೆ ರೆಕಾರ್ಡ್ ಮಾಡಬೇಕು. ಅದು ಇದೆ ರೆಕಾರ್ಡ್ ಇಲ್ಲಿ ಸರ್ ಆಡಿಯೋ ಬದಲಾಗಿದೆ. ಫಸ್ಟ್ ಎಕ್ಕ ಹೊಡಿಯುತ್ತೆ ನಾನು ಇಟ್ಕೊಳ್ಳಿ ಅದಕ್ಕೆ ನಾನು ಮಾಡ್ತೀನಿ. ಊಟ ಮಾಡಿದ್ರೆ ಎಲ್ಲ
ಮಾತಾಡಿ. ಹಲೋ ಹೇಳಿ ಹೇಳಿ. ಹಾ ಸರಿಯಾಗಿ ಕೇಳಿಸಲ್ಲ.
ಡೈರೆಕ್ಟ್ ಬರಲ್ಲ ಸರ್, ಅದು ಆಡಿಯೋ ಏನು ಬರಲ್ಲ.
ಮತ್ತೆ
ಏನ್ ಮಾತಾಡ್ತೀವಿ ಬ್ಯಾಕ್ ಮಾಡ್ತಾರೆ
ಈಗ ಹಂಗಾಗಲ್ಲ. ಇದಕ್ಕೆ ಆಡಿಯೋ ಕೊಡ್ಬೇಕಲ್ಲ ಅವರು.
ಏನ್ ಮಾತಾಡ್ತೀವಿ ಇಲ್ಲ, ಆಡಿಯೋ ಇಲ್ಲ ಇಲ್ಲಿ.
ಅದನ್ನ ಮೈಕ್ ಇಲ್ವಾ ವೈರು?
ಬರೀ ಸೌಂಡ್ ಬಾಕ್ಸ್ ಕೊಟ್ಟರೆ
ಅಲ್ಲ. ಇರಿ ಒಂದೆರಡು ನಿಮಿಷ ನಂಬರ್ ಬರಿದೆ ಅನ್ಸುತ್ತೆ.
Good morning, everyone. It's my privilege and honor to warmly welcome you all for this inauguration of the program Masterclass in Medicine Series 1, organized by Department of General Medicine, JSS Medical College, JSSAHER, Mysore. We begin the academic program with a small inauguration program. It's my honor to extend a warm welcome to our distinguished dignitaries. Firstly, I welcome our HOD sir, Dr. M. Suresh Babu sir, to the dais. I welcome our esteemed chief guest, Dr. Mukhya Prana Prabhu sir, Professor and HOD of Medicine, KMC Manipal. I welcome our guest of honor, Dr. B.J. Subhash Chandra sir, former HOD and Professor, Medicine Department. Dr. A. Manjula Madam, HOD, Mysore Medical College. I welcome our Vice Principal, Dr. Mantappa sir, to the dais. I welcome Dr. Ravi Kumar sir, a former HOD and Professor of Medicine. I welcome K.C. Shashidhara sir, Professor of Medicine. Now I request our respected HOD, Dr. M. Suresh Babu sir, to deliver the welcome address.
Good morning, everybody. It's my privilege and pleasure to welcome on behalf of Department of Medicine all the distinguished guests present on the dais and all the post-graduate students being present here. So, Masterclass of Medicine is a new experiment in my experience. this master class has been going on in different specialties. So I was wondering myself why we can't replicate the same thing in the field of medicine. And that is how this concept of master class in medicine became a reality today. As you all know, medicine is not just a science but also an art. It's not enough for us to have just the knowledge reading through textbooks. So the application of the acquired knowledge for diagnosis in a patient requires critical analysis of the history of the patient, requires critical reasoning, and then comes the critical interpretation. We belong to the generation of doctors where we have learnt medicine, practiced medicine through a difficult way. So that was the situation in the past where all of us come to this level. Now you are all in the scenario where artificial intelligence is playing a major role in every walks of life, including the field of medicine. So we are at the intersection between the past and the present. So now comes the question whether AI can replace medicine altogether. Because there has been a threat of AI in the field of engineering, where many people working in the field of engineering face a threat to their positions with the advent of AI. Can it happen the same in the field of medicine? I particularly feel, being in between the past and the future, AI cannot replace the human intelligence with respect to, at least I can say it confidently, in the field of medicine, general medicine. I don't know what happens in radiology, what happens in other branches of medicine. But as far as internal medicine is concerned, the past always will be the future, where you evaluate a patient, taking an appropriate history, doing a relevant clinical examination, and then interpreting the investigations. So belonging to the future generation, you should not feel that the history, the art of history taking, the art of clinical examination is a thing of the past. Understood? Because that's what you are easily tempted. Whenever you are asked a question, you are always tempted to look at your mobile phone using in artificial intelligence, trying to get the answer for it. We should use this artificial intelligence as complementary, and not that it is useless. It is complementary. You should not see it as competitive. So you should know when ideally artificial intelligence should be used in making an accurate diagnosis as much as possible in clinical practice. So that usually should be used after exhausting all the initial ways of evaluation in a patient. Then you will be well placed. You have come across situations yourself in your day-to-day practice where at the end of the reporting of all imaging studies or investigations, there will be a sentence where you are kindly requested to correlate clinically. Whether it's MRI or whether it's CT or whether it's culture report, always there is a sentence alerting you to correlate clinically. That itself should make you understand how much clinical evaluation is relevant in making a diagnosis. Understood? So, and you're all exposed to the clinical case discussions on almost a day-to-day basis. But you need to be looking forward, because the guests who are sitting here on the dais have acquired knowledge in their own hard ways through many people they have come across in their career. So they are all treasure houses of knowledge. So you as a postgraduate should be looking forward to get to know or to steal their expertise. Understood? And see that you become better physicians of tomorrow. Understood? So that is why we have planned from the Department of Medicine to organize these kind of masterclass in medicine once in 4 months. And we plan to get an expert in the field of medicine from other medical colleges, from other reputed medical colleges. So in that direction, Dr. Mukhe Prana Prabhu is the first person to be inaugurating the first of the series of masterclass in medicine being planned by the Department of Medicine. And to give a brief introduction of our chief guest, Dr. Mukhe Prana Prabhu, he is my senior in undergraduate studies, having done his MBBS from Mysore Medical College. Then he did his MD from Davangere Medical College. And now he is a prolific orator, being a guest speaker on many platforms across the country. And also he has to his credit, having guided a team of postgraduates across this country in an international forum of American College of Physicians. So that is the credit he has got. He has been guiding often the postgraduate team representing the country in the international quiz competition. It used to be held annually as a part of American College of Physicians internal medicine meeting. So now he is a well-established identity in the field of medicine, and you all should feel privileged to have him with you. Understood? We should see it as a golden opportunity. Instead of you being in his place, he has come to your place. So all of you should request to all of you to make best use of the opportunity. And also, I take this opportunity to welcome our former HOD of Medicine, Professor Subhash Chandra, who is the guest of honor of today's session. It is because of the guidance and cooperation being extended by former head of the Department of Medicine, Professor Subhash Chandra and Professor Ravi Kumar, we are able to do some programs so successfully. So it gives me pleasure to welcome Professor Subhash Chandra to this program. Also, I take this opportunity to welcome Professor Manjula, respected head of the Department of Medicine Medical College. So it is in that college I did my undergraduate and postgraduate studies. Again, it is a very reputed institution, having produced postgraduates who have been successful in different parts of the country and in the world. I take this opportunity to welcome Madam on behalf of the Department of Medicine. So I take this opportunity to welcome Vice Principal Dr. Mahantappa, who will be with us doing relevant course in all the activities related to the department. So I take this opportunity to welcome Dr. Mahantappa on this occasion. Again, I take this opportunity to welcome our beloved former head of the Department of Medicine, Dr. Ravi Kumar, who has been giving valuable suggestions in our departmental meetings. And it is for that reason that we are able to steer the department successfully to your expectations. And also, I take this opportunity to welcome Senior Professor Dr. Shashidhar, who holds an important position in the Association of Physicians of India Karnataka chapter. He is looking forward to head the association in future. He is the reason why we are able to do this program, where the benefits of this program will reach a larger student community. So the today's program has been publicized in different physicians forums on the national level, also at the state level, also at the local level. So interested students from different parts of the country will be looking forward to make the best use of this program through the Zoom initiative. So again, I take this opportunity to welcome and thank Dr. Shashidhar for having taken all the trouble and request him to have the same zeal, the interest in the further
ಆಡಿಯೋ ಬರ್ತೈತೆ ಅಂತ
master class in medicine, we plan the future of the
ಆಡಿಯೋ ಬರ್ತೈತೆ ಅಂತ Zoom ಅಲ್ಲಿ ವಿಡಿಯೋ ಬರ್ತಾ ಇಲ್ಲ
So, again, it is a pleasure to welcome the sponsors and students program, the banquet, who are always at the forefront to sponsor any academic programs. Again, I take this opportunity to welcome the people, most importantly, again, the chief coordinator of Department of Medicine, Prasad, who does and able to adjust himself well, both in the hospital administration and also in the departmental administration. So he fits in well into that program. I take this to welcome him also and all the people who are there from IT side to make this program a success. So thank you. And also I take this opportunity to welcome our staff, students, and all people who are present here. So the staff will be here for the inauguration process. Later students can continue the program with chief discussant of the program.
Thank you, sir. To mark the auspicious beginning of this academic program, I request all our dignitaries to kindly proceed for ceremonial opening of the lamp. Yes, sir. Now I request our Chief Guest, Dr. Prabhu, to share his words of discussion.
Good morning, respected senior professors, students, and all the sponsors. At the outset, I am overwhelmed by the invitation by my friend and colleague for last 35 years. So we know each other since 1989 as far as I remember. So when he asked me to come to JSS, it's a homecoming for me. It's my alma mater, MBBS. I did from Mysore Medical College, and I always consider Mysore as my home. So whenever called from Mysore, I will be very happy to come. And with the program, he told that it is a master class examination. I didn't understand what he told, and since he has invited, I hope I will try to do justice to because we, as a teachers, we day to day we have to teach, and role of internal medicine in present generation in the era of artificial intelligence and technology. Suresh Babu sir has already told. So as an internal medicine, we are like a Sharla's house. We cannot be replaced. I am sure that we will not be replaced because you go to a specialist, he can do an echo, he can do angiogram and stent. Patient gets better for that problem, but patient is not one problem or one symptom. So present day they see more complicated cases. As a person becomes 40 or 50, they will have multiple symptoms involved. They will have a chronic, they will have chronic kidney disease, they will have some amount of renal disease, heart failure, diabetes, hypertension is so common. Who has to deal with this? So as an internal medicine, we are the main treating doctors. And
Voice
as a rule, we are diagnostic. So diagnostic is a step home. Patient will come with some problem. He won't know what is the diagnosis. He will not tell. So what William Worcester, who is considered as modern medicine, is told take the to use your all senses. Talk to the patient. Use your eyes. Smell. Go to the patient. Touch him. Use all your senses. Patient will tell you what diagnosis. So with all situations possible, with the history and clinical examination, can make a diagnosis up to what I feel. You ask me. Then nowadays, if the patient comes with CT scan done or MRI done, maybe MRI, incidental patient symptoms may be entirely different. So this we need time to spend to the patient. But present day we don't have time. So patient will come with this many investigations. He says, please interpret this investigation and treat me. And sometimes they will, when you go to the patient will be waiting for you to touch him. So when you touch him, they say the disease is gone. So that is what our internal medicine is. As a postgraduate teacher, I have found that over a period of time, even the residency training has lost its relevance. Before patient comes, patient has got paraplegia, MRI would have been done, CT scan would have been done. Then the question comes, what is the problem with patient? Sometimes it may be just a hypokalemic periodic palsy. Potassium would not be done. So recently I had a patient who had a case of pituitary tumor, operated by a neurosurgeon, developed fever, they thought it's meningitis, LP done normal, then he developed Clostridium difficile treatment, enterocolitis, loose stools, he started bleeding everywhere. Then he developed pulmonary embolism, he had a thrombocytopenia. Who has to manage this? He had a cardiac problem, endocrine problem, neurosurgery problem, all problems. Then nobody wants to touch that patient. They dumped me on that patient to manage. Finally, I could not succeed. Patient succumbed because they had so many problems. I tried my best, and finally one day I gave up and I told the surgeons to open the abdomen. That was the end of it. Surgeons usually don't. They opened the abdomen. The patient went into coma. Till that he was conscious. So it's a really challenging job as an internal medicine. If you are aspiring to become a specialist, it's definitely agreed because present generation we need a super specialist or what you say subspecialist. But be confident in your internal medicine. Here we have got a very senior teachers, Professor Subhash Chandra, Manjula Madam, Ravi Kumar sir, Mahesh sir, Mantapa. Mantapa is my colleague in Manipal. He has written books on clinical medicine. And Srinath is there, Suresh Babu is there. So you have got enough teachers. The question is that how do you utilize? And this master class in clinical medicine during COVID, how to teach? It was a problem. So we had a similar problem. That time we used to do what is called telemedicine, in the sense Teams meeting. One person used to present the case and we used to transmit through this thing. But we always felt as medicine, it should be done in the bedside. Other departments, he told dermatology, radiology, they did lot of webinars. I have also seen. My wife is a dermatologist. She used to do every week, sit and teach in the district. That is very easy. Medicine teaching without the patient or from the web, I found difficult. It's my new experience for me also. At this opportunity, I would like to thank Professor Suresh Babu. I also want to start this program in some other way, but this will be the first program I will be doing teaching. What we say, there are students here. This is not entirely completely web based, but because it needs a lot of interaction, lot of coordination, and connectivity, all those things are there. So how do it goes? I don't know. Whatever is possible, I will try to do this thing. I would like to thank Professor Suresh Babu and JSS and all the postgraduates and the sponsors for giving me this opportunity. Thank you.
Thank you, sir, for your inspiring words. Now I request our guest of honor, Dr. B.J. Subhash Chandra sir, to share his words.
Good morning to every one of you. At the outset, I submit my humble pronouncements to the former pontiff and our founder of our esteemed institute, Rajendra Swamiji, and also I seeking the blessings of Deshika Swamiji. Respected Dr. Suresh Babu, Dr. Mukhya Prabhu, and Dr. Manjula, and all my respected other colleagues of the department, my dear postgraduate students. So indeed, Dr. Suresh Babu has taken an initiative in organizing this academic event, that is masterclass series of medicine. So Dr. Suresh Babu has given a very detailed information about that, how this masterclass medicine is going to work. Okay, recent years, all of us are witnessing there is a drastic deterioration in the application of clinical medicine and quality of clinical medicine also. So for all these things, we give explanation that because of this, the innovation of this diagram, that is imaging studies and laboratory innovations, higher end laboratory innovations. But this is not true. Okay, nothing is replaces the clinical medicine. So the history and the clinical examination has got a paramount importance in the evaluation of the patient. So there are so many incidences we can quote an example. So if the patient comes with a headache, so the patient doesn't have any of the much of risk factor, no evidence of no history suggestive of ICP, no focal neurological epilepsy. Subject him immediately to the imaging studies. So imaging studies comes normal. It is later retrospectively go and see there is an evidence of the erythematous rashes, some amount of vesicles are appear. It may be simple herpes zoster, doesn't require. Similarly, patient comes with chest pain on the left side, and ECG has been taken. There are some non-specific changes. They have not examined the patient, undressing the chest and other thing. They have taken immediately to the cath lab and do an angiogram. It found that it's a normal. And afterwards, they found out why this is happening. There is an evidence of the herpes zoster, the dermatoma distribution on the left side. So all these things are so there are so many conditions. You can only have a clinical diagnosis. So rabies, you cannot have anything. Even the tetanus, we don't have. Even that matter, day to day, we discuss few people in the clinical seminar, the motor neuron disease. So it's all clinical diagnosis. So we do some investigations in the conditions like motor neuron disease to exclude the treatable diseases or the which can be easily treatable and can give a complete cure. So in that condition, so what I am stressing is the clinical medicine has played a paramount role in this one. No investigations or no higher end or even the basic. So one should interpret the investigations with the background of the history and clinical examination, clinical diagnosis. So just straight away going to the investigation is not. So in this regard, I appreciate and congratulate and compliment Dr. Suresh Babu for taking the initiative to arrange this clinical master series in medicine. Okay, and one point I wanted to highlight is no any member of the medical faculty examine the patient as a whole. The only person who does holistic examination and diagnosis is the clinical medicine. This is what you should be proud. I'm very proud of that. So I think all of you feel that is the essence of this my talk. So I thank for calling me and I say yes and give me an opportunity to tell about all these things, share my experiences behind all of you. Thank you very much.
Thank you, sir. I request Dr. Manjula ma'am, Professor HOD in to share her thoughts.
And good morning, everybody. I would like to present the clinical examination. This is the most important. Examine the patient as a patient is acceptable. And we can replace it. So, we will important to the clinical examination of the patient. So, this is a program. Focus on a lot of value represented and thanks to the initiation of this program. I thank everybody for giving me an opportunity to be a part of this program. Thank you.
We now come to an end of this integration program. We hope that this masterclass in medicine brings insightful discussions and meaningful learning throughout the day. Wishing you everyone good luck. Thank you.
Your knowledge is improving by tomorrow.
ಈಗ ನಿಮ್ಗೆ ಹೆಂಗ್ ಗೊತ್ತು ಪೇಷಂಟ್ ಎಲ್ಲಿರ್ತಾರೆ ನನ್ನ ಕ್ಯಾಮ್ರಾ ಎಲ್ಲಿ ಫಿಕ್ಸ್ ಮಾಡೋದು
ನೋಡ್ಕೊಂಡು ಫೋಕಸ್ ನೀವು ಒಂದು ಕಡೆ ಅಲ್ಲೆಲ್ಲ
ಸರ್ ಇಲ್ಲಿ ಹಾಕಿದವ್ರ ತಲೆ ಎಲ್ಲ ಬರುತ್ತೆ ಇಬ್ರದ್ದು ಮತ್ತೆ ಸರ್ ಅಲ್ಲೇನಾ ಬೆಡ್ ಅಲ್ಲೇನಾ ಸ್ವಲ್ಪ ರೈಟ್ ಸ್ವಲ್ಪ ಲೆಫ್ಟ್ ಆದ್ರೆ ಸಾಕು ಪೇಷಂಟ್ ಡಿಸ್ಕಷನ್ ಎರಡು ಬರಬೇಕಾ?
ಪ್ರೆಸೆಂಟ್ ಮಾಡಿದಾಗ ಈ ಆಂಗ್ಲಲ್ಲಿ ಹಾಕಿದ್ದು ಮತ್ತೆ ಮೇಲೆ
ಅವ್ರ ಪೇಷಂಟ್ ಇಲ್ಲಿ ಬರ್ತಾರಲ್ವಾ ಅವ್ರು ನೀವು ಅಲ್ಲೆಲ್ಲ ಹೋಗಿ ನಿಲ್ಲಲ್ವಾ? ಅಲ್ಲ
ಅದಾದ್ಮೇಲೆ ಈ ಕಡೆ ఈ కళలు ఇవన్నీ కదా
అదే కదంటే మీరు ఎంగా తలుపు చూడండి
కెమెరామెన్ ఏం చేస్తాడని
వాడికి యాంగిల్స్ కావాలి
ఆయన అడగమన్నప్పుడు
ఎనర్జీ ఫోకస్
you can sit here.
that's better. I think.
ఉందా
కెమెరా కొంచెం లెఫ్ట్ కెమెరా అడ్డు వస్తుంది అలాగే కెమెరా
Zoom connect.
Start as the operator.
ನಿಮ್ದು ಬಂದ್ಬಿಡ್ತಾ ನಾನು ವಿಡಿಯೋ ಆಫ್ ಮಾಡ್ತೀನಿ. Managed to make 4 students. Go back in the next.
ಅದು ಮುಂದೆ ಏನಾದ್ರು ಇಡ್ಬೇಕಾ? ಅಲ್ಲಿ ಮುಂದೆ ಇಡಕ್ಕಾಗೋದಿಲ್ಲ ಬಿಡಿ, ನಿಮ್ಗೆ ವೈರಸ್ ಹಾಕಾಗಲ್ಲ. ಇವ್ರು ಎಲ್ರಿಗೂ ಸ್ವಲ್ಪ ಈ ಕಡೆ ಇಲ್ಲ ಆ ಥರ ಹೇಳಿದ್ರೆ ಇಲ್ಲಿ ನಿಮ್ಮ ಪೇಷಂಟೇ ಗೊತ್ತಾಗಲ್ಲ. ಇಲ್ಲ 1 by 1 ಮಾಡಬೇಕಾಗತ್ತೆ. ಫಸ್ಟ್ ಅದು ಮಾಡಬೇಕಾಗತ್ತೆ, ಇಲ್ಲ ಇದು ಮಾಡಬೇಕು. ಝೂಮ್ ಮಾಡಿ ಝೂಮ್ ಆಗುತ್ತೆ, ಬೋರ್ ಆಗುತ್ತೆ, ಏನು ತೊಂದರೆ ಇಲ್ಲ. ನನಗೆ ಕರೆಕ್ಟೇ ಹೇಳಿದ್ರೆ ನಾನು ಏನಾದರೂ ಒಂದು ಐಡಿಯಾ ಮಾಡ್ಕೊಳ್ತೀನಿ. ಫಸ್ಟ್ ಅದನ್ನು ಮಾಡ್ತಾರೆ, ಫಸ್ಟ್ ಇದನ್ನು ಮಾಡ್ತಾರೆ.
ಇಲ್ಲ ನೋಡಿ, ನಾನು ಅಲ್ಲಿಂದ ಸಜೆಸ್ಟ್ ಮಾಡ್ತೀನಿ. ಓಕೆ, ಪೇಷಂಟ್ ಇದಿರ್ತಾರೆ. ಓಕೆ ಸರ್, ಓಕೆ ಇವಾಗ ಪೇಷಂಟ್ ಮಾತಾಡಲ್ಲ.
ಬರೀ ನೀವು ಮಾತಾಡ್ತೀವಿ,
ನಾವು ಮಾತಾಡ್ತಿರ್ತೀನಿ, ಸರ್ ಕೇಳ್ಕೊತಾ ಇರ್ತಾರೆ.
ಫಸ್ಟ್
ಸೆಕೆಂಡ್ ಹಾಫು ನನ್ನ ಎಕ್ಸಾಮಿನೇಷನ್.
ಓ ಇದು ಆಡಿಟೋರಿಯಂ ಸಿಡಿಯಂ ಬಿಡಿ ಸರ್, ಏನು ತಲೆ ಸಾಕಲ್ವಾ? ಅಲ್ಲೇ ತಗೊಳ್ಳಿ, ಮತ್ತೆ ನಿಮಗೆ ಇಲ್ಲೆಲ್ಲ ಇರ್ಬೇಕು ನೋಡಿ. ಇಲ್ಲಿ 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 ನಿಮಗೆ ಲೈಟ್ ಹಾಕ್ಬೇಡಿ ಸರ್, ಅಲ್ಲಿ ಬೇಡ.
ನೀವೇ coordinate yourself. Coffee ಎಲ್ಲ ಬಂದ್ಮೇಲೆ coffee people should give the coffee. You can have coffee there. No flux.
It's a new experience for me. So, good morning. There will be interactive sessions. It's a new experience for me also. So, hope we will do good. Yes. How many of you are from Mysore Medical College? How many are from JSS? Anybody from Mysore Medical College resident? It's not working. Anybody from Mysore Medical College? Or all are from JSS? Okay. How many are first years? How many are first years? Nobody is there. I think all are exam days, all are fine days, and 20 hours. So exam is in the month of August, September. You just give me the notes I made this thing. Yeah. So we will first do the neurology case. So over to Dr. Srivalla Puja. Okay, yeah.
Good morning.
Yeah.
Good morning, everyone. Presenting a CNS case today. Patient identification.
Can you be little louder? Do you need a mic?
No, sir. No, it's fine. 40-year-old female, educated in the 10th class. He is a beautician by occupation. He's Bangalore resident. Date of examination was on 24th and informant is self. This patient came with chief complaints of weakness of both lower limbs since 24 days and complaints of difficulty in passing urine since 24 days. She was in her usual state of health until 25 days ago, when she developed vomiting 5 to 6 episodes in a day, which was non-bilious, non-projectile, non-blood stain, and contained food particles, and it was not associated with fever. She was taken to a local hospital where she was admitted and started on intravenous medications. On the same day, in the evening, she developed back pain, which was deep-seated, diffuse, non-radiating, and associated with a bad-leg sensation. Later that night, she developed an urge to pass urine and was able to walk to the washroom independently without difficulty. However, she was unable to avoid urine. She returned to the bed, following which she developed a lower abdominal pain, which was dull aching and continuous in nature. Next morning, at around 9:30 a.m., she developed severe pain in both lower limbs, extending from mid-thigh to toes. The pain was symmetrical, deep-seated, and dull aching and non-radiating. At around 10 a.m., within half an hour of onset of pain, she developed weakness of both limbs, lower limbs, which was rapidly progressive, associated with a sense of heaviness and tingling sensation, and was unable to move both lower limbs and lost sensation, including the ability to perceive clothing over the affected areas. She was referred to a higher center where she was admitted to ICU for further management. She was catheterized with a Foley's catheter, following which her abdominal pain was relieved.
Okay, that's the pain history. Further is there? Yeah.
She received treatment and was subsequently discharged. She is currently undergoing rehabilitation. She reports a band-like sensation around the trunk at the level of umbilicus. She also reports a reduced perception of pain and temperature below the level of umbilicus. She also gives a history of bowel incontinence. She also reports loss of sensation in the perianal region, history of difficulty in rolling over bed, needs upper limb support. There is no improvement in the weakness as of now. So, coming to negative.
Okay. Before the negative history. So, can go back to the history. First symptom is actually she has presented with both lower limb weakness. Okay, so in medicine, in neurology, so whenever there is a weakness can be neurological or it can be generalized weakness. So she has got a weakness of both lower limbs. So anybody feels that it's a neurological problem or is it a outside problem? Generalized. If a patient with anemia can have weakness. Patient with heart failure can they have weakness? Patient with liver disease can they have weakness? So in this patient, is it a neurological weakness or is it a generalized weakness? How do you say? What is your impression? First, she has got to come with a lower limb weakness. Many times, patient can say that I got a weakness. Is it a common symptom? The most common symptom, one of the common symptom is a weakness. So it could be due to so many diseases, starting from anemia. Patient with anemia, can they feel weak to walk? They can have also weakness. What are the features suggest it is when the both lower limb weakness, in a neurological term, it is a paraplegia or paraparesis. Okay. So what do you think? It's a neurological. How do you say it's neurological?
So it is neurological because it was acute in onset. Sir.
Onset is acute. Yes.
And bilateral symmetrical weakness.
Both lower limb weakness. Yes.
And, along with motor and sensory both.
Patient has got a motor symptoms, sensory symptoms. That suggests it's a neurological. Then
and also associated with other symptoms like bladder.
Urinary bladder involvement, that again suggests it's a neurological problem. Then,
and also associated, initially associated back pain followed by the weakness.
another symptom which is suggested it's a neurological problem, she had a backache. So all this suggests that the patient has got generalized weakness due to anemia, diabetes. The symptoms will not be like that, only lower limb weakness, these motor symptoms will not be there. So she has come with a neurological weakness. Neurological weakness predominantly affecting the lower limbs. What we say, it's a paraplegia. Okay. So what is the next symptom she had?
The first symptom was vomiting, sir.
Oh, she had a vomiting. Okay.
Vomiting in the morning, 5 to 6 episodes, sir. Not associated fever or abdominal pain. Later in the evening, she developed a back pain.
Okay. So vomiting, do you think it's a significant symptom in this patient? It's a significant symptom. Okay. What is the cause of vomiting?
So it can be.
Is it due to raised intracranial tension? Is that features of raised intracranial tension?
It doesn't look like raised intracranial tension. Vomiting was non-projectile. And also not associated with altered sensorium or other symptoms.
Not associated with the fever. Not associated with vomiting. Okay. So first symptom is a vomiting. So do you think it is relevant to her present problem? What way? Okay. So if the person has got repeated vomiting, patient has come with a neurological weakness. One possibility is a hypokalemic periodic palsy. Otherwise, patient has come with vomiting, lower limb weakness. Can it be? Can be GB syndrome. Okay. Yes. Anything else? Actually, vomiting, is it a preceding symptom of GB syndrome or?
Usually diarrhea, sir.
Usually preceding diarrhea about 2 to 3 weeks before. Okay. So that is a symptom suggestive of GB syndrome. Vomiting, it's either what you have to think, is it a gastrointestinal problem, whether she had taken any of this thing, or is it related to any non-projectile, non-blood-stained food particle? So for the vomiting, she went to the hospital?
No, sir. Yes, sir. For vomiting, she went to the hospital. And in the evening, when she went to the hospital, she developed back pains.
Okay. After going to the hospital, she developed back pain. So vomiting must have been a persistent symptom. Okay. When she reached the hospital, she developed a back pain. Again, back pain. Can you describe that back pain? There is the back pain.
The back pain was deep-seated, diffuse, and non-radiating, associated with a band-like sensation.
So when you get a back pain, you should be able to tell where is it, upper back, mid back, or lower back. Is it? So upper back pain is related to cervical spine problem. Mid back is what we get is a thoracic cord. Lower back is a lumbar spine. So if the person has come sudden onset of low backache pain and radiating to down with a bladder bowel involvement, what do you think commonly? Disc prolapse. Okay. Yeah. Whereas neck pain persisting for some time, later develops a neurological weakness. Either it's a spondylotic this thing. Mid thoracic pain persisting for some time, then started developing a neurological weakness in the form of lower limb. It could be extradural abscess like a tuberculosis or a tumor. So in this patient, she had a back pain, which was early benign. She is pointing out to mid back, lower back or mid back. She is telling lower back. Okay, so lower back pain. ಕೆಳಗೆ ತನಕ ಹೋಗ್ತಿತ್ತಾ ಇಲ್ಲ ಎಷ್ಟು ದಿವಸದಿಂದ ಅವತ್ತು ಮಾತ್ರ ಬಂದಿದೆ ವಾಂತಿ ಬಂದಿದ್ದೆ ಊಟ ಹೆಚ್ಚು ಕಮ್ಮಿ ಏನಾರ ಆಗಿತ್ತಾ ಸರಿಯಾಗಿ ಏನು ಪ್ರಾಬ್ಲಮ್ ಇರಲಿಲ್ಲ ಓಕೆ ಸೊ ಶಿ ಸೇಸ್ ಲೋ ಬ್ಯಾಕ್ ಏಕ್ then actually she is probably, I don't know when it was happened, 2 months back. Is she able to remember properly? She remembers.
First of this month.
Okay, so low back ache is a lumbosacral region. So whether she had a pain, yen madbekar benno bantu. Okay. She is telling after repeated vomiting, she started developing a pain. Okay, retching. Okay.
So same day she developed back pain which was deep-seated, diffuse, non-radiating. What are the different types of pain you get in a neurological symptoms? Classically is a radicular pain. Can you describe the radicular pain?
Radicular pain will be radiating
Typically, she doesn't have. Correctly. Does she have? No. Typically, radicular pain is a sharp, shooting, electric shock-like pain, radiating along particular dermatome, increases on sneezing, coughing. Okay. Then second type of pains, funicular pain. What is funicular pain?
Funicular will be deep and diffuse.
Deep, diffuse,
Not radiating.
not along the dermatome.
Not along the
Whole this spine, whole part. Okay. Third type of pain,
posterolateral column pain.
lateral. Okay. What is the typical pain?
Paresthesia, tingling and numbness.
Well, that is due to peripheral neuropathy pain, tingling, numbness, paresthesia. Posterior column pain, like band-like sensation kept over the whole limb. Okay. Then last one is a vertebral pain, which will be deep-seated pain, boring pain, disturbs even movement, and also persists throughout the day and night. It may disturb the sleep also. So her pain, which was deep-seated, non-radiating, eagle venom edema. So after giving some injection, pain has subsided according to. Next symptom.
So the same after the back pain in the night, she had developed an urge to pass evenings.
Okay.
And she was in the ICU at that time, and then she herself went to the washroom, and there was no difficulty.
She was able to walk to the washroom.
And there was no difficulty in sandal people. She wore chappals and she went to the washroom, sat, and then there was no problem standing up from squatting position also. And but when she went to void, she was unable to void urine. For which she returned to bed, following which she developed lower abdominal pain, which is blood aching and continuous in nature.
Okay. So what is this symptom suggestive of? So, yes.
So this bladder incontinence suggestive of flaccid type bladder.
What is this? What kind of bladder? Bladder involvement was the first to be noticed. So instead of lower limb weakness, she noticed a bladder weakness. What does it suggest? It's a neurogenic bladder.
Neurogenic bladders.
Due to what conditions cause bladder involvement first?
Sir, transverse myelitis.
Transverse myelitis, yes. Then?
And also complete
complete card transaction. So what type of bladder which she had initially?
Sir, initially she had she had urge to pass. Sensation of bladder was there, but when she went to void, she was not able to pass.
Okay.
Which can be secondary to spinal shock phase. And
spinal shock, that time she didn't have any.
She didn't have any weakness.
Weakness. Probably the first manifestation of transection of the spinal cord. It's a, what is that? What type of bladder? What are the different types of bladder you can get?
Sir, it can be either human type of bladder or element type of bladder.
Okay. So what is this?
So looking like element type. Also urge to pass was there, sir.
So she had a sensation. Is it element bladder?
No, human bladders.
Why human bladder?
So because
it's a retention with overflow. She is not able to void the urine. So it's some card problem above the level of S2-3. So it suggests that patient has got some neurospinal cord involvement. Probably, yes. Then she was not able to work. Then she noticed weakness of both lower limbs.
So next, this was in the night.
Occurred over a period of.
This was in the night at around 2 a.m. So till morning she had only abdominal pain. At around 9.
Abdominal pain. What is the cause of abdominal pain? It's a bladder distension. She is feeling the bladder was full. Probably she was not able to pass. That's the cause of her bladder abdominal pain. Okay, next.
So next morning at 9:30 a.m. she developed severe pain in both lower limbs, which extended from mid thigh to toes.
Mid thigh to
toes. Bilaterals.
Symmetrical deep seated. What does it suggest?
It suggests that it is a spinal cord problem, sir, which was
spinal cord problem level. Where the problem?
Around L3.
So mid thigh localizes to what?
Around L3. Sir.
L2, above that. Okay, above that, and she had a backache also. So is it related to L1, L2 or above?
Yes.
Mid thigh above the level, she could not get the sensations. She felt that what was the weakness level that time?
initially she developed only pain, sir.
Pain.
Which was
Okay, but
mid-thigh
ಆಗ
to
ನಡೆಯಕ್ಕೆ ಆಗ್ತಿತ್ತಮ್ಮ ನಿಮಗೆ ಫಸ್ಟ್ ದಿವಸ ನಡೀತಾ ಇದ್ವಿ ಹೋಗಿ ಬಂದ್ವಿ ಮೂತ್ರ ಮಾಡಕ್ಕಾಗ್ಲಿಲ್ಲ ಅಂತ ನೀವು ಬಂದು ಮಲ್ಕೊಂಡ್ರಿ ಮತ್ತೆ ಹಾ ಇಲ್ಲ ಹಾಸ್ಪಿಟಲ್ ಓಕೆ ಶಿ ವಾಸ್ ಇನ್ ದ ಹಾಸ್ಪಿಟಲ್ ಶಿ ಡೆವಲಪ್ ಓಕೆ ಹಾ ಹಾ ಮೂತ್ರ ಮಾಡಕ್ಕಾಗ್ಲಿಲ್ಲ ಅವ್ರೇನು ಟ್ಯೂಬ್ ಹಾಕಿದ್ರ ಆಗ ಇಲ್ಲ ಓಕೆ ನೆಕ್ಸ್ಟ್ ಡೇ ಏನಾಯ್ತು ಕಾಲ್ ನೋವು ಬಂತು ಓಕೆ ಹಾ ಸೊ ಶಿ ಹ್ಯಾಡ್ ಎ ಸಿವಿಯರ್ ಪೇನ್ ಓಕೆ okay, so she says what she told is that what is the symptom, anybody can understand? She told heaviness of the leg. So what does this heaviness of leg indicate? Weakness, or is it a sensory?
Heaviness.
It's a weakness. Many times patient tell weakness as a loss of sensation. Sometimes they can. So heaviness of the limb. So it is actually motor weakness. Patient, even in the stroke, many times when the patient has got hemiplegia or one weakness, so they will say that that limb has become heavy. They are not able to use it. Sometimes you get confused. Is it a sensory? ಆಗ ಮುಟ್ಟಿದ್ದೆಲ್ಲ ಗೊತ್ತಾಗ್ತಿತ್ತಾ? ಆಗ immediately. ಕಾಲು ಎತ್ತಕ್ಕಾಗ್ತಿತ್ತಾ? ಇಲ್ಲ. Okay. She noticed both lower limb weakness, sudden onset, or what is that? Morning, early morning. Okay. Next, what happened?
Sir, initially what happened was at 9:30 am she first developed pain, sir. And then within half an hour, husband was massaging her both lower limbs. When she was able to feel the touch and the pain both, but immediately after half an hour, at around 10 am, she developed weakness of both lower limbs, which was rapidly progressive, associated with a sense of heaviness.
Okay.
And tingling sensation, and was unable to move both lower limbs and lost sensation, including inability to pursue clothing over the affected areas.
After that, she went to ICU.
Yes, ICU. She was in the night. She was in the ICU only. At around 2 am, she developed bladder symptoms.
Okay.
Morning 9:30, first she developed pain.
Can you interpret this together? No.
So initially she developed bladder symptoms, and then the pain.
Anything else you have got in the history or not? Nothing else.
That's it. First pain, which can be.
Can you summarize the history? What are the possibilities?
40-year-old, sir.
So in the medicine, so either young person, middle-aged, or old age. She is in the middle-aged lady. Yes, she has come with the
vomiting first.
Okay, vomiting. I will take it as a non-neurological. So, okay, now she said she is vomiting. Adu say na ute ಹೆಚ್ಚು ಕಮ್ಮಿ ಮಾಡಿದ್ರಾ? Okay, so vomiting becomes neurological when headache, vomiting, associated with projectile vomiting. Okay, so this patient noticed this headache, vomiting. Other than that, so this patient, I don't know, lose motion ಏನಾಗಿತ್ತು ಅವತ್ತು? Vomit ಮಾತ್ರ ಆಗಿತ್ತು. Okay, so vomiting only was the symptom which made her observe this thing. Okay, any other way vomiting can be associated here? Neurological symptoms. What are the neurological things vomiting can be associated? Meningitis, migraine. Okay, commonly this thing the patient can have migraine, vomiting can be there. Then in posterior circulation stroke. Anything else? Tumor, raised ICP. Yes, trauma, where head injury, post head injury headaches. Then the patient can have persistent vomiting. Then any condition where you got only vomiting as a symptom of neurological. Posterior fossa tumor and area postrema. Okay, when you start vomiting, patient cause is not found. So usually vomiting commonly used due to GI tract. Then comes hepatitis. Then anything related to abdomen or GI tract, urinary disease. You might have had vomiting because of the abdominal distension, also possible. So UTI, anything can cause vomiting. Then you have to see vomiting. Unusual causes include cardiac. Patient is an elderly person, or sometimes can vomit. It could be inferior wall MI. Patient can have vomiting, can be due to repeated vomiting going on, can be due to Addison's disease. endocrine causes, it can be Addison's disease. Patient can have vomiting, non-abdominal can be due to diabetic ketoacidosis. Patient can have vomiting due to drugs. Commonly we prescribe for painkiller, tramadol. It can cause persistent vomiting. And then women, if you don't ask history, it could be related to pregnancy. Porphyrias, repeated vomiting can be there with abdominal pain, and neurological problems can be there. So when the patient has got vomiting, in this patient I will attribute more to probably she had abdominal problem which caused vomit. Then she noticed that she had got neurological pain. Okay, so what is her neurological problem? Both lower limb weakness.
Both lower limb weakness and bladder.
In the bladder involvement, with the sensory involvement. So when this kind of, so you should know how to approach a case of paraplegia. So neurological weakness is a paraplegia. Presentation is a paraplegia. It's a straightforward case of paraplegia. With the weakness, the grade you didn't tell. What is the grade when she had initially?
Sorry,
now she is able to walk.
No, sir. Sudden onset, which was paraplegia only, sir.
Sudden onset. In the neurology, what is the importance of onset of the illness? Whenever there is acute onset, we say acute onset means within minutes to hours, not in terms of days. Anything within 1 or 2 days is still also acute. What is the onset of illness indicates the etiology. Neurology onset is very important. How did it start? Her history is suggestive of within 1 day. Is it a minutes? What are the neurological weakness which can occur problems within minutes?
It's true.
More than the vascular event, it's a seizures and trauma. These two things are very acute. First is most important is electrical event. Patient develops a seizures. It will be within minutes. Next comes a vascular event. Vascular event will be within minutes to hours. Again, based on the history, you can see is it onset is immediately or within hours. Most of the time, whatever the acute event is there, we take it as a vascular event. Second event which can occur in the neurology, very rapid onset is what?
Stroke.
Demyelinating illness. Okay, so demyelination. Classically, multiple sclerosis. Usually, it is not within few hours, minutes or hours. It will be over a period of hours, but it can be dramatic. It can be also within few minutes. So, onset of illness next is after vascular and electrical event is a demyelination. Second thing which can occur over a period of what you say hours to days can be infection and inflammatory. So most of the time infection cannot occur suddenly. It has to be over a period of hours. So most of the time what infection can present neurological distinct? Meningitis, meningoencephalitis commonly. Yes, then anything that will come as a inflammatory to this thing that will not come within minutes. Meningitis, and again in the spinal cord there can be rarely infections can like a transverse infection. So it occurs over a period of not within minutes or hours. It will be a period of days, maybe up to weeks. Okay. Then it comes in the neurology, days to weeks. Most important is again infection. Demyelination also can come like that. Then comes inflammatory diseases. Some common inflammatory diseases which can present in neurology. Yeah, post-infectious. That's a post-infectious demyelination.
Epidural abscess.
That's still months, weeks to months. Yeah.
Epidural abscess, port spine.
Port spine. So port spine is not directly treated. It's a secondary to epidural abscess due to tuberculosis. It will occur over a period of, it's an inflammatory mass compressing and then secondary consequences. So any tumor can be benign, it can be malignant, or it can be some mass lesions, or it can be bleeding. Bleeding will be acute to subacute. Okay. So then comes in neurology, which is a slowly progressive without improving. So usually slowly progressive, weeks to months to years is a degenerative disease. So paraplegia can be acute, subacute, it can be chronic. So tell some causes of acute paraplegia. So like this case, yeah.
Transverse myelitis.
So first one is, as I told, if you take it as this thing, trauma, it falls from the ground, height, injure the thoracic spinal cord, thoracic vertebra, fracture, dislocation. So patient will attend. The history is important, fallen from the height, back. Okay. Second thing.
Spinal cord infarction.
Whiplash injury, hyperextension injury can be very rapid, particularly motor traffic accident. Okay, then in the vascular problem, it's a thrombosis of a spinal artery. Usually, it's again at the thoracic anterior spinal artery thrombosis can occur and it can cause sudden onset in the sense over a period of few hours. That's below the, particularly commonly anterior spinal artery thrombosis occurs around T8, T9 level because it's a vascular territory, watershed area. So you can get a weakness below the, all four limbs will not be there. Next.
Complete cord transection.
So then comes the neurological causes, central causes. What are the causes where you get a central cause which can cause paraplegia because it's an acute onset?
Bilateral ACA.
Not bilateral. Usually it's a very rare to get a two artery territory getting occluded simultaneously. Thrombosis of unpaired anterior cerebral artery where there is a involvement of the both lower limbs plus bladder involvement because parasagittal lobule will also be involved. So patient can have a thrombosis of anterior cerebral artery can present like that. Second thing, anything central cause? Parasagittal meningioma. Again, what will be the history there? Headache, vomiting, and the patient gets down. So again, parasagittal meningioma, it will be little slow. If there is a bleed into the tumor, they can present acutely. Third cause which can cause central cause which can come as a paraplegia. Superior sagittal sinus thrombosis. Superior sagittal sinus thrombosis. Patient is, it's a venous thrombosis. Usually there will be history of headache, vomiting, followed by neurological weakness, usually paraplegia, but again the weakness will be. So in this patient, do you think it's a central or spinal cord problem? So when the patient has got a paraplegia, usually first thing we think is a spinal cord. So what are the features which make it suggest it's spinal cord problem rather than central?
The spinal cord, there is definite sensory levels.
So patient has got anything when it involves the motor, sensory, bladder, you have to think of spinal cord. So in this patient had a first symptom as a bladder involvement, then the weakness and sensory occurred together. If it was a case of stroke, what would have been the feature? Patient would have predominantly weakness. Sensory, motor, bladder involvement can be there, but again more predominantly motor weakness. So in this patient, it looks like a spinal cord problem. So what is the problem then? What is the etiological? Onset is acute. So is it a thrombosis of anterior spinal artery, or is it infection, or is it a inflammatory problem? Infection or inflammatory problem or thromb? Why not it is a vascular thrombosis?
Vascular thrombosis,
Because she had acutely, according to you. Yeah.
So it only involves anterior cord.
So it will be anterior cord syndrome. Here, what are our symptoms is suggestive of a complete transaction. So it cannot be anterior spinal artery thrombosis. Then two things are left. What are those things? Either it's infection or inflammation. So infection, usually whenever there is infection, one most important symptom will be fever. Post-infective demyelinating symptom, again, there should be some amount of fever which can be not noticed. So what are the causes of infective transverse myelitis? So if it is a symptom of transverse myelitis, what are the causes of?
So Epstein-Barr virus.
So common viruses won't cause. So these are most of the time viruses. What are those? Yeah, yes.
Epstein-Barr virus, CMV can cause.
Epstein-Barr virus, CMV.
Tuberculosis also can cause.
So is it common to present tubercular thrombocystitis? So Epstein-Barr virus, common presentation, what is it? Is it common to present like this? Epstein-Barr virus, what is the disease commonly? How does it present? In a medical one, not neurological disease. It's usually pharyngitis. Patient will have, it's called infectious mononucleosis. Patient will have a fever, sore throat. Any other features? Lymphadenopathy may be there. Third, severe lymphadenopathy will be there. Anything else? Classically, you give ampicillin for sore throat. Patient immediately will develop the rash. So that is the typical Epstein-Barr virus. Okay. So again, they will have a clinically plus no some hepatomegaly, splenomegaly, fever will be there, rash will be there, lymphadenopathy. It's also called kissing disease. Common in young adolescent males can occur in this thing, kissing disease. Then they will have rash. They can have typically hepatitis. What type of hepatitis? Electric hepatitis. Patient will have a no jaundice, AST/ALT will be elevated. And there will be
ಕ್ಲಾಸಿಗೆ ಬರಲ್ಲ ಯಾರು ಬರಲ್ಲ.
or IgM. So that is typical Epstein-Barr. Other viruses which can come as a transmission. Herpes simplex virus, as a third told herpes zoster. So herpes zoster typically severe before the eruption of the vesicular lesion. So herpes simplex can rarely present as a transmission virus, more commonly in a immunocompromised. So next is varicella zoster virus. Cytomegalovirus. Typically cytomegalovirus can cause, but what is the typical cytomegalovirus commonly seen in? Immunocompromised, particularly retropositive, and the CD4 count is less than 50. And actually, is it a presentation is like a transverse myelitis, or typically CMV is a differential diagnosis for what? In a retropositive or diarrhea can be there. Meningitis can occur. What is the typical CMV meningitis? Periventricular calcification. Okay, and then fundus you see. What is it? Choroid tubercles? No. What is it? It's a vasculitis. So it's again
Splash tomato.
Okay. So that is typical of CMV. Whereas toxoplasmosis in the fundus will look like a not angry looking flash in the fog in the district. Okay. Whereas CMV presents typically, what is the typical presentation when you have to think of CMV? Retinitis can be there when you see the fundus. Visual loss can be there. Okay. And neurologically, I must be. It's usually polyradiculopathy. Typically, like presents like a cauda equina syndrome. Severe radicular pain. Patient will have radicular pain. Cauda equina is what? Typically radicular pain, wasting, bladder and bowel involvement will be late. Whereas in the transverse myelitis, bladder involvement will be early. Patient will have a motor sensory level. So CMV presents like a differential diagnosis for cauda equina syndrome, and patient will have a highly immunocompromised. HSV can occur. So infection, tuberculosis, can it present like a transverse myelitis? It can be extremely rare. Tuberculosis, what is that? Tuberculoma. So can present as like an intramedullary lesion. Patient can have a paraplegia, and again history of fever, weight loss, or loss of appetite. All those things can be. Next. Okay, so what are the other ways? CMV, HSV, herpes zoster. Bacterial infections which can present like a
Lyme's disease.
Lyme's disease, which we don't commonly consider. Lyme's disease is one disease which can present like this. Actually, there are few case reports from the Kerala where the patient can have Lyme's disease. Usually it presents like a facial palsy and like a sarcoidosis, and also can present as a transverse myelitis. Okay, it's due to Borrelia recurrens. Okay, so Lyme's disease is one disease with bacterial infection. And then there are rarer reports due to leptospirosis, scrub typhus can present like a transverse myelitis, but not typical features. Okay, when the patient has a transverse myelitis like feature, is it due to post-infectious? Then first comes the inflammatory. What are the inflammatory diseases? Vasculitis,
and
due to SLE, neuromyelitis optica,
and
demyelination due to multiple sclerosis,
long antibody disease.
long acting disease, then sarcoidosis is rare. So these are the possibilities which are left as a presenting like a transverse myelitis. Okay, next you can go. Any doubts about it? Anybody else wants to add anything? So first you have to decide whether it's a cord lesion. Anything else can present like a lower limb weakness, more commonly in the ward, which you would have seen. Most of the time, it's a patient is not able to walk, both lower limb weakness. Is it a GB syndrome? Like, it's a straightforward question. Very commonly, GB syndrome. Can it present like this? Usually ascending paralysis, correct? But bladder involvement in this patient strongly says it's not, and complete loss of sensation says it's not. Because many times when the patient has got lower limb weakness, first thing commonly, which is common disease, is a Guillain-Barré syndrome. Usually not so rapid. Sensory motor bladder. Bladder is strongly against the Guillain-Barré syndrome. So Guillain-Barré is unlikely. So question remains is transverse myelitis. So what kind of transverse myelitis? What is the distinct? Any other doubts about this case? The history level. Yes. Bladder involvement is there initially. What are the conditions where you got bladder involvement earlier? I already told. Okay. Yeah.
Negative issues. No history of upper limb weakness.
So her upper limb is completely normal. Okay.
No history of facial deviation despite the discovery of slurring of speech.
Okay.
Lower cranial pulses and upper cervical myelopathy ruled out. And no history of electric shock-like sensation radiating down the spine and neck flexion.
What did you mean by that?
Sir,
okay, there are two signs which you classically get in a multiple sclerosis. One is Lermit signs, another is the Ulthoff phenomenon. Okay, so Lermit sign is also called Barber's care sign, and again it can be also seen in any posterior column. It's a posterior column involvement. It can be seen in even cervical spondylosis. Okay, yes.
And there is no history of loss of consciousness, syncope or convulsions. No history of trauma to spinal head injury. No history of cardiopulmonary symptoms. Sometimes aortic dissection under aortic
Okay,
aneurysm.
what a vascular arterial thrombosis, spinal artery thrombosis, it occurs commonly in a cases of predisposed cardiac, as I told, aortic dissection. So this patient can also repeated vomiting. But what will be the typical history in aortic dissection? Tearing pain, radiating to the back, and the asymmetrical pulses. Okay, so that kind of patient, the 40-year-old, unlikely to be thrombus unless you have got a severe risk factor for atherosclerotic disease. Yes.
And also cardioembolic also can cause sometimes
Cardioembolic stroke. So cardioembolic stroke usually goes into
central brain.
usually go to MCA territory. Large MCA stroke, patient is conscious. Usually it's hemiplegia, but multiple emboli can go and cause
spinal cord ischemia.
Spinal cord ischemia. Rarely, what is that syndrome? Involvement of the emboli going into the bifurcation of common iliac artery. There is syndrome. Again, commonly seen. It's not a very acute symptom. Patient will have both lower limb weakness and impotence in a male. Yes. No history of substance abuse or toxin intake. What substance?
Amphetamine, cocaine can sometimes cause aortic dissection and also cause
it can be cannabis. Okay, so these are all
predisposed to thrombosis.
Okay, hypercoagulable state. Okay, yes.
And IV drug abuse can directly cause septic emboli.
Septic emboli. Okay, yes.
And the toxic intakes like lead and arsenic very rare.
Okay. I think neuroletharism. So again, it's a history is a progressive over a period of multiple. Okay, next.
So no complaints of loss of vision or painful ocular movements. These symptoms are suggestive, which could suggest optic neuritis.
Okay.
Which usually
so can it be first episode of multiple sclerosis?
multiple sclerosis first episode usually optic neuritis.
So it's not like that. It's a multiple sclerosis is a disease which has got a varied presentation. So patient can come first time with the transverse myelitis. Patient can come first time with the visual loss. Patient can come first time with the abnormal movements. Patient can come with the first time involvement of only bladder. So multiple sclerosis is a disease where you got a disseminated in time, race in the same person. Okay, so varied presentation. So multiple sclerosis is usually disease of pure white matter. So it can present at varied time. So can it be a first episode of multiple sclerosis? Onset is acute, subacute can be there, and first symptoms she had a bladder involvement, bladder fibers can be alone involved, and same day she can have this thing progressive.
Usually, multiple sclerosis comes with patchy involvement of
usually, it's not a complete transaction. It's usually partial transaction, and again, some fibers are more predisposed in multiple sclerosis, some are less. What are the fibers commonly involved in multiple sclerosis? Most predominant is a optic nerve, which can cause a retrobulbar neuritis, sudden loss of vision. Second most common in the brain, medial longitudinal fasciculus, internuclear ophthalmoplegia. Patient has got a diplopia, sudden onset of diplopia. When there is a bilateral ILO involvement, there is no diagnosis unless otherwise put due to multiple sclerosis. Third common is another white matter in the brain. This thing is a cerebellum. Patient can come with a vertigo. Patient can have ataxia, tremors. Then the pyramidal fibers, they are predisposed to it. Then patient can have a bladder fibers, that is again predisposed. Again, posterior column fibers with the symptoms like a sensory. So sometimes, many times it may be confused as a psychiatric illness. Less commonly, lateral spinothalamic cord or a full involvement. So patient has got a complete transaction. Still, it could be multiple sclerosis, but less likely because of the predominantly it is presents as a single tracks, patchy involvement. One card can be involved. Again, previous history, if it is there, it's strongly there. But first episode, we should keep it as a possibility. But complete transaction, less likely. Okay. So, what is any other possibilities?
So, no history of fever, rash, or any recent viral illness prior to onset of.
Okay. So, important is a vaccine induced. Vaccine induced, can it be usually presents like a more commonly GBC. But again, vaccine can cause transverse myelitis. So post-infective or post-vaccine demyelination can occur, particularly which vaccines? Influenza vaccines can cause, then polio vaccines can cause. Earlier days, they used to use neurotropic anti-rabies vaccine. So it used to be the most common causes of that. So nowadays, we don't use it commonly. So vaccine induced, what is recently COVID vaccine induced syndrome? What is it called? Vaccine induced thrombocytopenia thrombosis syndrome. Have you heard about it? This syndrome was very prominent during COVID time. What was that? Particularly, what was the vaccine which we used in India? Covishield. So that vaccine, particularly the women, they used to have a sudden onset of thrombosis, particularly causing cerebrovascular corticovenous thrombosis, thrombocytopenia. Many people died. That's called vaccine-induced thrombocytopenia, thrombosis syndrome, which was as well. There was a thrombocytopenia and not bleeding, it was a thrombosis. So that can also be one of the complications which you get if you have got a history of COVID vaccination. Okay, next.
So there is no history of back pain worsening with the movement of cough, this back pain.
Okay, so what does it suggest? Involvement of vertebra. Okay.
No history of similar neurological.
What are the vertebral problems which can present with the paraplegia? What is most common in India is a quad spine. Any other disease which can present like a spondylo?
Disc prolapse can cause a
Disc prolapse. Can it cause paraplegia?
Uncommon but can cause.
So normally commonest site for disc prolapse is L5S1. There is no card there. Thoracic vertebra disc prolapse rare. cervical vertebra disc prolapse can occur. So it usually causes quadriplegia, but rarely paraplegia can be there. Initially, sudden neck pain followed by quadriplegia. Upper limbs will improve, lower limbs may remain weak. So cervical disc prolapse can occur. Thoracic vertebra, the disc space is there such that disc prolapse doesn't happen. Whereas commonly get what is intravertebral disc prolapse, L5S1, typically they will have back pain, rarely bladder and bowel involvement, they will not present with the paraplegia. Okay, yes.
So that's about HOPs. Past history. She was diagnosed with SLE with lupus nephritis in 2021. When patient was evaluated in view of multiple joint pains with early morning stiffness.
So she is a diagnosed case of SLE based on the American Rheumatologic Disease. Okay, so that's a very important history in a female who has got on top of the SLE. Okay, yes.
Also in 2024, patient had abdominal pain and swallowing difficulty, for which she was admitted and diagnosed with GI vasculitis and is on medications for the same.
Okay, so she had a seizures also. So what are the neurological manifestations? SLE is a primarily the disease of connective tissue, autoimmune disease. Commonly, 90% of cases are women. What are the typical presentations? You know, is the most common involvement is a dermatological rash. Second most common involvement is a joint arthritis. Third most common involvement internal organ is a kidney, that is a lupus nephritis. Then it can involve any other system. Heart can be involved in the form of myocarditis, pericardial effusion. Lung can be involved in the form of pleuritis, pleurisy can occur. Then abdomen can be the peritonitis. The patient can have a rarely autoimmune pancreatitis, autoimmune hepatitis. Neurological involvement, what are the neurological involvement of SLE?
Usually comes with seizures.
Usually most common is a neuropsychiatric. Patient can have a psychosis because of the illness or underlying depression. Second thing, neuropsychotic symptoms are very common in SLE. Then
Seizures.
Headache. Headache can be an attributable symptom. Seizures. Second, third thing, seizures. Then
Can present with strokes or vasculitis.
Patient can have vasculitis, can present like a stroke.
And usually associated with secondary aplasy.
It can be associated with the secondary Apla syndrome. Then
and
patient can have vasculitis, can have mononeuritis multiplex. Then
spinal cord thrombosis.
Can be involvement transverse myelitis like presentation can occur. Then
and hypercoagulable state.
Hypercoagulable state patient can have a cortical vein thrombosis. Then dementia because of the multiple vascular risk factors and this thing can occur. So SLE can have varied presentation. If the patient has got a SLE, like this patient who has got SLE, who has come with neurologically with this thing, and they are also prone for infections. Particularly, they will be an immunosuppressive. Tuberculosis is more common. They can have TB meningitis, TB spine, and all this. Okay. So she had a SLE. Okay. History of seizures. Okay. Next.
2010, patient is history of after a surgery for likely fibroid retention, saying some gut pain, hypercoagulation.
Okay. So you can take it as a fibroid or something which we can relate. Okay. Next.
Sir, she was shifted to post-op right after the surgery, sir. 4 to 5 hours after which patient had stiffness and posturing of all 4 limbs, suggestive of GTCS.
Okay.
She was diagnosed to have seizure disorder and is on medication for the same. She has had 5 to 6 episodes after the first episode. Last episode was 5 years back.
Okay.
And she's a non-hypertensive medications for this.
Okay. Yes, next. Non-hypertensive. Okay. So at the age of 40 years, hypertension in a patient with SLE, it could be due to lupus nephritis. Okay. Yeah, vasculitis and okay. Yeah.
Not a known case of diabetes, USD or previous CVA. No history of similar episodes in the past. Coming to personal history,
Anything specific is there? No.
No.
Yeah. She is on catheter even now.
Yes.
Correct? No? She has not regained this bladder sensation. She is almost 24 days over as far as this. Okay. ಎಷ್ಟು ದಿವಸ ಆಯ್ತು ನನಗೆ 25 ದಿವಸ ಆಯ್ತಾ ಈಗ ಮೂತ್ರ ಗೊತ್ತಾಗತ್ತಾ ಗೊತ್ತಾಗಲ್ಲ ತೆಗೆದು ನೋಡಿಲ್ಲ ಓಕೆ
diet predominantly vegetarian. Bowel and bladder, bowel incontinence is there. Bolus catheter is insipid. Sleep is adequate and undisturbed, no habits. Family history, no family history of stroke, hypertension, or diabetes, no history of similar complaints in any of the family members. And menstrual history, she attained
40. She has got a probably premature menopause. If you take
Yes.
any history of abortions, only one child you have written.
Sir, only one child. I asked, sir, there is no history of abortions.
Okay. So why it's important to know the APLA, secondary APLA syndrome is common. There is a history of recurrent abortion and also venous thrombosis. Because she had a seizures, it could be APLA syndrome. Yes, next.
Obstetric history, one child, non-vaginal delivery, 23 years back. Medication history, she is prednisolone 20-300. Levetiracetam, hydroxychloroquine, folate, losartan, and she has taken cyclophosphamide induced once a month before in 2022.
Okay, only once an injection was given.
No, sir. Every month she used to take.
Okay, so that is called, they must have given a pulse therapy for a lupus nephritis stage 3 and 4.
And this early menopause could be attributed to cyclophosphamide, so premature
Okay, yes. Okay.
Activities of daily mobility, depending for walking, she can't walk. It's not able to move.
Yes.
Bladder,
So whatever is my existing limitation, I can't examine her with this thing. Okay, yes, next.
Bladder and police catheter. Bowel incontinence is there, requires assistance for bowel.
Anybody else has examined other than him?
Yes. So,
Good. Because I can't make her lie down and yes. Next.
Feeding is independent, dressing is dependent because of lower weakness, and bathing is dependent, personal hygiene partially dependent. Coming to summary,
Can you summarize? Yeah.
a known case of SLE with lupus nephritis with GI vasculitis on treatment, presented with acute onset, rapidly progressive weakness of both lower limbs and urinary retention for 24 days. Illness began with vomiting, non-releasing, non-projectile without fear, followed by back pain with band-like sensation. Within a day, she developed acute urinary retention, severe bilateral lower limb pain, and rapid progression to paraplegia with sensory loss. Currently, she has sensory level at umbilicus.
Can you say sensory level at umbilicus at the history level?
So she has band-like sensation.
She told band-like sensation. Yes, if you say that band-like sensation, where did you told? Because your backache is lower down.
Yes, she told at the level of umbilicus, she says.
ಎಲ್ಲಿಂದ ಗೊತ್ತಾಗಲ್ಲಮ್ಮ, if you can tell clearly, if she tells, ಎಲ್ಲಿಂದ ಗೊತ್ತಾಗಲ್ಲಮ್ಮ ನಿಮಗೆ? ಎಲ್ಲಿ? ಮುಂದ್ಗಡೆ? She is saying that is it this area is what? Around the umbilicus. She is not even pointing umbilicus. She is pointing it to the level of T8 level. Okay, and she is telling both lower limbs. Okay, so that is corresponding to that level. Okay, yes, and umbilicus, if you tell correctly, if the person points out like this, anybody can point out particularly umbilicus. Yeah.
And the loss of pain and temperature below bowel encountering perianal sensory loss.
Okay, perianal sensory loss she could tell.
We asked her.
Motion ಮಾಡೋ ಜಾಗದಲ್ಲಿ ಗೊತ್ತಾಗಲ್ಲ ಗೊತ್ತಿರೋಲ್ಲ ಮೇಲ್ಗಡೆ ಅಲ್ಲ ಎಲ್ಲಿಂದ ಗೊತ್ತಾಗತ್ತೆ ಇದು she is telling specifically, but perianal I don't know, because whole thing is she is not able to.
So while wiping, when bowel care is being given, she is not able to feel during the wipe.
Okay, yes. Next.
And no cranial nerve, upper limb, trauma or infectious problem.
Okay. So provisional acute transverse mobility SLE associated because patient is a case of SLE. Why not it's APLA?
So no history of recurrent abortions.
History of abortion is not there. Then anything else? Again, APLA syndrome can present like a transverse myelitis, which is very acute. Thrombosis can present. Okay.
So NMOSD, because two of the main criteria, so main is area postuma syndrome, so can cause hiccups and vomiting.
Okay. Then
myelitis, usually transverse myelitis, a longitudinally extensive transverse myelitis, because there is severe paraplegia with bowel and bladder.
Okay. So
incontinence.
Epidural abscess or hematoma, you have kept at 4 possibilities. Is it possible? Anybody presenting in acutely backache, should you consider it as epidural abscess?
The backache with rapidly progressive weakness, first
we should consider as you have to rule out that as a possibility. What condition can present? Sudden backache. Only thing missing is a history of fever. Okay. So what is the common cause of epidural abscess?
TB staph, bacterial
TB
infection,
strain will be little
staphylococcus,
subacute, can be
staphylococcus, bacterial
spinal
infection.
anesthesia possible then.
I will
Staphylococcus, which is
Staphylococcus.
treatable. Epidural abscess can be due to Staphylococcus endocarditis. Patient can have staphylococcal epidural abscess. If you miss it, you are going to lose the patient. So epidural abscess, which has got a severe tenderness. Okay, so it can present like a transverse myelitis. Patient can present with a compression lesion, and it can be within 1 or 2 days. So rapid epidural abscess. Another thing which can have tuberculosis and brucellosis are the close differential diagnosis. Brucellosis you should consider. And hematoma, if the patient is on not an anticoagulation, if she was on anticoagulation, hematoma due to minor trauma could be the cause. Okay, next. Okay, good. So examination. Any doubts about that?
Patient is conscious and oriented, time-based and person.
You are built that term well built and moderately nourished. You feel that well built? Anybody can say she is well built? Yeah, better term is because most of this chronic illness and then normally built is based on the standard for the population and the sex. So Indian females approximately 55 to 60 kg and height of 5.5. So Western ladies tall this thing. So if Indian lady is like a Western lady, then you can say well built. So she is not even tall. And again she has got a chronic illness, and I will not expect her to be well nourished. Whatever she is a hospitalized patient. So this is simple logic in the exam. Better unless patient is a endocrine well built on this thing. Most of the Indian standard males is about 5 to 8 this thing, about 60 kgs. Otherwise tall well built male is very rare to be having this thing. Again female this thing. So she doesn't look like that. Okay. So when you are used this term again, I saw that well built and well modeled. I thought, okay, yes. Well built people cannot have illness, they can also have illness, but not commonly presenting as an acute or chronic illness. Okay. And she has got a chronic illness. Yes.
No failure, rectal sinuses, clubbing, Olympic and pepidal.
Okay, no neurocutaneous marker. What are the neurocutaneous markers you see in a case of paraplegia, quadriplegia? What are the things you see? Neurofibromatosis presenting as a, what are the findings? Markers. Cephalospat, then adenoma sebaceum is due to tuberous sclerosis. Does it present as a paraplegia, but present is seizures and mental retardation? Okay, cephalospots, then neurofibromas. What will be the marker? It is a what indicates in the spinal cord? What does it present? Neurofibromas can have
intramedullary
intramedullary, intradural. Okay. Again, it can neurofibroma can have a bilateral CP angle tube. Okay. So these are the two things. Okay. So any other neurocutaneous marker? Chagrin patches again seen in tuberous sclerosis. Tuberous sclerosis presents usually as a mental retardation. Okay. Next one is what is it?
The ferropenum is better also.
What is that? Cerebellar hemangioblastoma. It is cerebral arthritis. Okay. Then yeah. Again, cerebellar hemangioblastoma. So these are the neurocutaneous markers, and they got paraplegia. Neurofibroma is important, which can be again one side. It is in thoracic side. Okay. Yes.
So no extra markers connected tissue disease.
What are the connected external markers?
Sir, in SLE usually we see a non-scarring alopecia, oral ulcers.
Oral ulcers. She has got a murderosis. How many bilateral are there? What is that tongue? How is the tongue? It's a mole. Okay. Many times students confuse it with cyanosis. Okay. She's got a mole. Okay. Then after ulcers you have to see. And then any rash, it's a discoid rash. Okay, then they can have a cutaneous ulcers, okay, and they can have what is libido reticulars. Net-like race-like pattern seen in the usually in the lower limb distribution. Okay, so that can be seen. Okay, then lateral examination. Anything else is there? She's got a gross pyramidal, no?
Post camera problem ಇದೆಯಾ?
Even if it is not fitting, is it a
ಸೂಪರ್ ಆಯ್ತಾ ಇರೋದು?
what is she has got here?
ಯಾರು ಹೋಸ್ಟ್ ಮಾಡ್ತಾರೆ ಯಾರು?
It is ulcer. She has got a significant edema.
ಅವರು ಕನೆಕ್ಟ್ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ ಅಲ್ಲಿ.
So, what does this non-fitting edema indicate?
ಲಿಂಕ್ ಕೊಟ್ಟಿದ್ಯಾ? ಮಾತಾಡ್ತಿರೋರು ಲಿಂಕ್ ಮಾಡ್ತಾರೆ.
Venous infections are possible. Even the fitting edema initial stages. Later it can be
connect ಮಾಡ್ಕೊಂಡ್ಬಿಟ್ಟಾರ ಅಂತ.
So she has got significant edema. So it could be due to either lupus nephritis.
ಕ್ಯಾಮೆರಾ ಏನಾದ್ರು ಮಿಸ್ಟೇಕಾ? ಕ್ಯಾಮೆರಾ ಒಂಚೂರು ಇದು ಮಾಡಿ.
Scleroderma can present.
ಇಲ್ಲ ಒಂಚೂರು ಇಂಟರ್ನೆಟ್ ಇಲ್ಲ ಒಂದೊಂದ್ಸರಿ ಕರೆಕ್ಟ್ ಆಗಿ ಬರ್ತಾ ಇದೆ.
But edema is
ಲ್ಯಾಪ್ಟಾಪ್ ಅಲ್ಲೂ ಅದೇ ಲೈನ್ ಬರ್ತಾ ಇದೆ.
Pulses are not palpable. Dorsal expedition
ನಿಮ್ದು ಬರ್ತಾ ಇದೆ. ನಮ್ಗೆ ಇಲ್ಲಿ ರಿಲೇ ಆಗಿ ಬರ್ತಾ ಇರೋದು ಡಿಸ್ಟರ್ಬೆನ್ಸ್ ಬರ್ತಾ ಇದೆ. ಎರಡು ಲೈನ್ ಬರ್ತಾ ಇದೆ.
regular rhythm, normal.
ಸೌಂಡ್ ಬರ್ತಾ ಇದೆ.
Bilateral dorsal expedition posterior lateral.
ಇದು ಬರುತ್ತೆ ಒಂದ್ಸರಿ ಹೊರಟೋಗುತ್ತೆ.
No paralytic breath. Blood pressure is 134/80.
ನಿಮಗೆ ಸ್ಪೀಡ್ ಇದಾಗಿಲ್ಲ ಅಂತಂದ್ರೆ ಆಯ್ತಾ ನೋಡಿ PPT ಓಪನ್ ಮಾಡಿದ್ರು ಬರ್ತಾ ಇದೆ ಬಟ್ ಅಲ್ಲಿ ಬರ್ತಾ ಇದೆ ಡಿಸ್ಟರ್ಬೆನ್ಸ್ ಎರಡು.
Which cranial nerve is important in the paraplegic case?
Second cranial nerve.
Second is most important, but again, lower cranial nerves, seventh nerve. Second cranial nerve, why it's important?
Optic neuritis.
Optic neuritis seen in multiple sclerosis.
Neuromyelitis.
Neuromyelitis.
ಮಾಡ್ತಾ ಇದ್ವಿ ಆನ್ಲೈನ್ ಪ್ರೋಗ್ರಾಮ್.
Yes, then.
ಇದ್ರದಲ್ವಾ?
More antibody.
Okay, more antibody. But other causes, paraplegia with eye involvement. Can papilledema occur in paraplegia due to GB syndrome? Then cases of Friedreich's ataxia. Vitamin B12 deficiency. Subacute combat degeneration can have this thing. Okay, then thrombosis of unpaired artery circulatory can have papilledema. SND, what you get? The fundus. You can see the vasculitic changes. I'm not able to get the term immediately. Vasculitis can be seen in the, I've forgotten the term which is seen in vascular. So you can pick up the, what is it? Retinal vasculitis can be seen. Okay, SLE patient. Okay, because it's active vasculitis. If I get it right. Okay, next. Fundus exam. Then seventh nerve is important. Bilateral facial palsy, paraplegia or quadriplegia is a GB syndrome. Again, neurosarcoi. Okay. Then lower cranial nerves.
Lower cranial nerves in CV junction anomalies.
CV junction usually paraplegia, but can be quadriplegia. Can you name something? Arnold Chiari is not a CV junction error, it's association. You will have cerebellar sites. Then triple field syndrome is what? What is the neurological abnormality?
So usually we see spinal deformity and cerebellar.
Usually it's a fusion of the lower cervical vertebra. It doesn't cause neurological. It's associated. You can get what is called mirror image movements. Patient does this. Movement occurs in a triple field anomaly. So again, it will be associated something else. Okay, next.
Occipitalization of atlas.
Occipital atlas. Again, same thing. Lower cranial nerves can be involved.
Dandy walker malformation.
All these kind of associations. Okay. So atlantoaxial dislocation usually presents with sudden onset of the quadriplegia. Okay, platybasia. Then triple field again CV junction anomaly will be associated. Dandy walker, Arnold Chiari, all are associations. Next.
Secondary causes like osteomalacia, Pellet's disease
can be involved in the
cranial nerves all normal.
Next.
Motor system, upper limb power is normal, so lower limb from paraplegia 0
So 0 power. That's the thing is possible for her. Okay.
So there is no evidence of wasting cerebral.
Wasting is not there.
Wasting is not
Okay.
there. No fasciculation. Beaver sign is positive.
Okay, what is Beaver sign? Can you tell?
Sir, on neck flexion, on supine position.
Noted. Okay, yes.
Patient in supine position, on neck flexion there is upward.
Ask the patient to And the next,
upward displacement of umbilicus.
umbilicus. What does it indicate?
So lower abdominal, lower trunk muscle weakness.
ಅವನು ರಿಲೇ ಮಾಡ್ತಾನಲ್ಲ, ಫೋಕಸ್ ಮಾಡ್ತಾನಲ್ಲ, ಅವನು ಕ್ಯಾಮ್ರಾ ತಪ್ಪಿದ್ರೆ ಕೇಬಲ್ ಪ್ರಾಬ್ಲಮ್.
Cards.
ರಿಲೇ ಮಾಡ್ತಾನ ನೋಡಲಿ.
So we will say
start ಆಗ್ಬಿಡದ ಪ್ರೋಗ್ರಾಮ್.
at the level of this. These card and vertebra are different levels. Is there anywhere else you are saying is seen? This is specific facioscapulohumeral dystrophy. Is a described in classically compressive lesion or non-compressive lesion at T10 vertebrae get because of the weakness below over normal being normal. It umbilicus goes up rarely then with the liver villus. Okay, but it's again seen in commonly seen in compressive myelopathy, non-compressive myelopathy at the T10 thoracic card involvement. But commonly non-compressive lesion which can be seen is a facioscapulohumeral. Next.
Reflexes biceps
Absent. So that's another question. Okay, next. Anything else?
plantar mute abdominal.
Absent.
Upper and lower.
You have tested. Okay. Plantar, both sides absent. Okay.
Fine touch
ಕ್ಯಾಮ್ರಾ
Umbilicus corresponds to what level? T10 vertebra. Not vertebra.
temperature lost 2 centimeters below umbilicus.
Find out why it happens like that?
Because it crosses 2 segments.
It crosses, goes up 2 segments above and then crosses. Okay. Is there a band-like sensation?
It is there. Umbilicus in which she is seeing it. Vibration lost in the bilateral and anterior superior spine, joint position to angle in a given group of cerebral sense negatives are upper limb.
You are tested.
Tested upper limbs.
If there is only one hand, if there is ataxia in this patient with a card like this, history is not typical. It could be multiple sclerosis. Okay, spasticity or cerebral tremors. Upper limb you don't have, can't put the lesion in one level. Okay, yes. Next.
No,
here it is a straightforward one level. Okay.
Give us before or spinal bifida. No spinal bifida is vertebral. Skull and skull
Okay. So now in a neurology, first is how do you give a diagnosis? So what are the deficits? What are the structures involved? Where is the lesion? Okay, now you tell that all the components.
The neurological deficit, symmetrical lower limb classic paraplegia.
Symmetrical
lower limb classic.
Bilateral lower limb. Again, lower limb and classic paraplegia both are required. Paraplegia is lower limb, so no, not required. Okay. Classic paraplegia is sufficient. Okay, lower limb is obviously meaningless. Okay.
So in this one doubt I had was this bladder because bladder sensation is still initially.
I'll come to that. Bladder will come. Okay. With the bladder and bowel involvement, you can write it. One bladder classic. Okay. With the sensory loss. Okay. So what you can do? Patient has got a motor pyramidal tract, all the sensory tracts and bladder fibers involved at the level of
umbilicus.
You have not put the level there.
I see. The level of umbilicus.
Horizontal level, you have put a complete card transaction at the vertebral level. This thing card level.
T10.
Okay. Next. Sensory below 10. Motor T10. Motor 10 T10. How did you come to know?
So Beaver sign.
Beaver sign was present. Okay.
And reflex level because abdominal reflex was absent.
Absent T7. Okay. Vertebral level T5. So do you think it's a vertebral problem? So if you think it's a vertebral problem, you are saying a transverse myelitis. So if you feel that, where should you press for the spinal tendons? T10 is there. Where should you go?
So 3 above.
2 or 3 segments above. T7. Okay. If you have got a vertebral level, so if you're pointing out vertebral pathology, you can say. Here, it's not required. Okay. It's a card problem. Okay. But you have to examine the T7, T8 vertebra. Okay. So pathology, complete card transaction. That's correct.
Etiology, non-compressive.
Non-compressive transverse myelopathy. Okay, due to SLE, probably vasculitis. Okay, now we come to the bladder. Okay, what do you think the bladder? She is not still regular. Two questions I will ask here. Patient has got a complete absent reflexes even after 24 days of this thing. Is she element paraplegia or is it human paraplegia?
So usually
In this patient, she has got a signs of, according to you, hypotonia, absent reflexes, then classic paraplegia. Okay, is it element or human?
So anal and bulbar cavernous reflex, if we had checked
In the males, okay, this is females, yeah.
And anal reflex.
Is it a neuronal shock?
Neuronal shock could be said.
Neuronal shock usually lasts for
24 days.
Up to 4 to 6 weeks.
4 to 6 weeks. It's not over.
Okay, I thought it's longer than that. Okay, so when you have got a longer period, patient has got element signs, particularly in cases of hemiplegia, after even 2 to 4 weeks, some people don't recover. In this case, it is not 4 to 6 weeks. Still, you can assume it to be neuronal shock. When the recovery occurs, what will be the first thing to occur?
Anal and bulbar cavernous.
Bulbar cavernous in this, okay, not possible then.
Anal reflex will occur first.
Anal reflex.
And the
plantar can come down,
plantar.
okay, and then the tone may recover, power may recover, okay. But here, if you have got still all the signs of element, what are the other explanations can be there?
So one is spinal shock.
Neuronal shock. So spinal or neuronal shock. Yes. Then.
Second, it could be element bladder because of complete cord transection.
Complete cord transaction.
Used to be
because in this patient, still she is on catheter. Whether she has regained the sensation, we don't know, and very unlikely because she is not having a sensation still now, not there. So when it recovers, it will become a, what is the typical patient recovers from the bladder?
Spastic bladder.
Spastic bladder. They will have a bladder gets full, small bladder and automatically wise. Urgency this thing will be. In this patient, with the power being absent, recovery of bladder will take much more time. It's very difficult to predict it now. And patient has got all the reflexes absent. What are the other explanations can be there? GBC. In this case, it's not GBC. Okay. Complete cord transaction, including the anterior horn cell, is involved. So complete is gone. It's a case of hematomelia or vascular infarction. So element signs may persist. Whereas in hemiplegia, if that doesn't occur, it is the involvement of the other tracts. Here also all tracts are gone. Probably that could be the cause of even the element signs. Okay. So what is the first investigation you do here? So it could be SLE vasculitis or Apla syndrome. But one thing is that she doesn't have previous history of that, but she had a seizures. So it could be still a SLE vasculitis. How do you differentiate based on the investigation?
The investigations are
first investigation. What do you want to do in this patient? First, you have to rule out is a local in the sense
spinal.
MRI of the spine. Okay, whole spine is required in this patient. Why? If there is any patchy involvement, is it a multiple sclerosis? So if it is a arterial spinal artery thrombosis, it can be shown. Sometimes there is anything. And number of segments involved. If you do it T8 or thoracic vertebra, thoracic card only, you will miss it. Can you tell this thing?
This is MRI.
Can you read the final report?
Final impression, multifocal long segment, non-enhancing intramedullary T2 hyperintense signal involving cervicomedullary junction and spinal cord as described. T2 flare hyperintense.
Cervicomedullary junction means again same thing. Card is higher, but your reflexes were normal. Upper limb is normal.
T2 hyperintensities in cerebellar junction and dorsal medulla. Imaging features are suggestive of longitudinal extensive transverse myelitis in given clinical context, likely lupus.
Can you say that because there are one lesion in the cervical, another lesion down,
no.
Or is it a whole segment involvement there?
Here they have given in cervical spine C4, C5, C5, C6, C6, C7.
Okay, down thoracic spine. So it's a long segment.
Long segment.
Okay. Why upper limb is not involved?
Sir, actually, reflexes upper limb, right
You have
side.
written normal, no? I didn't see.
It was normal only, sir, but
That is a difficult these things. Okay. If there is a long cervical segment is involved, you should get either human signs in the upper limb or some sensory loss. So here there is a low. So when you get simultaneously, it's okay. Otherwise, it's a multiple sclerosis. Multiple sclerosis or vasculitis, lupus vasculitis. But again, two areas simultaneously occurring is very important. ಕೈಗೇನ ತೊಂದರೆ ಇತ್ತಾ ಯಾವಾಗಲೂ ಈಗಲೂ ಹೇಳ್ತೀನಿ ಊಟ ಎಲ್ಲ ಮಾಡೋಕ್ಕಾಗತ್ತೆ. So multifocal long segment non-enhancing intramedullary T2 hypersignal involving a cervicomedullary junction spinal cord. So in a patient with cervical involvement, why the lower limbs are more involved? It is pure water, but here it is doesn't fit in. If it is a transverse myelitis at T2 level is fine. But many of the cord involvement in the cervical spine, you can get a lower limb involvement. Why?
upper limb fibers are
Pattern of pattern of involvement of the lower limb fibers. If it is a compressive, if the cervical spinal cord also, lower limb fibers are compressed first, and again, sometimes you will get a pure motor paraplegia also in a cervical spondylosis. Explanation is a pyramidal tract has got a high metabolic stick and compression it is more and ligament flavor. So these are the things which can and without sensory involvement. In this patient, it is a transverse myelopathy. The MRI may show something. It is probably T2 segment, T8, T10 segment. And if there are any lower element signs here it is all partly because of the neuronal shocks. If you have got a definite element signs in particular event, you can tell that it's. So when you got a card involvement, how do you localize? What is the most important?
sensory levels.
Sensory level, if it is classically there, and the band of hyperalgesia. Next is reflexes. Okay, then comes the motor. So based on that, you can look. In this patient, she is pointing out to the umbilicus. It has to be T10 thoracic card. So next question is it a vertebral involvement? Very unlikely. We have not seen any. So T10 vertebral, not card involvement. 2 or 3 segments. So is it a multiple sclerosis or is it a neuromyelitis optica?
So usually more than 3 longitudinal segments. LETM is usually commonly seen in NMO HTC.
NMO can be there, but what is the most important another finding which should have been there?
Area post.
Optic neuritis. Again, these diseases can be autoimmune disease can be associated during the SLE patient. Patient can have a complete vision loss, usually bilateral. Whereas multiple sclerosis, how do you differentiate?
Unilateral.
Usually unilateral vision loss, card involvement. Then patient can have a painful vision loss. Then ocular movements can be involved in the form of nystagmus or ophthalmoplegia or ILO involvement. Then anything else suggestive of multiple sclerosis? Any other involvement in the past? Okay, then the segments will be smaller, 1 or 2 segments. It's not like this long segments. And usually multiple sclerosis is a multiple types. Patient can have a progressive. Whereas neuromyelitis optica is usually single phasic. Any other which you can involve the card and brain. ADA, MOG and ADA. These are the things which can be kept as a differential diagnosis. So any other next investigation you want?
MRI brain.
The MRI brain has to be done, yes, to rule out any white matter plaques in the brain. Then next, lumbar puncture. Lumbar puncture, CSF report is there?
So we couldn't get the reports.
Okay. CSF is important. If it is a case of MOG or neuromyelitis optica, what will happen? Cells will be increased, and in the neuromyelitis you get a antibodies. Anti-muscarinic antibody will be positive, and again cells will be increased, proteins will be increased. If it is a vascular infarction or vasculitis, what will be there? CSF will be normal. Okay. And Apla syndrome, CSF will be normal. What are the other clues to suggest of Apla? APTT will be prolonged. Patient will have antibodies. Anticardiolipin. And with the history of family history of disease, she had a seizure. What is the APTT is important? Is it a Apla associated? Because there's a long segment. Multiple. And again, it's not explains this thing. Okay. So, in the treatment wise, if it is a transverse myelopathy, pulse steroid therapy is indicated. In again SLE vasculitis, there are very few indication of pulse steroid. What we say is pulse steroid is 1 grams IV for 3 days. One is a vasculitis, lupus nephritis, alveolar hemorrhage, and the active vasculitis. So if the active vasculitis is there, patient dsDNA will be showing high titer, urine C3, C4 will be low, patient will have proteinuria. She has got active because she has taken only for the course of this thing. You should know what is her lupus nephritis status. Okay. Anything else? Any other? So if it is the APLA syndrome, secondary APLA, anticoagulation, preferably warfarin based therapy, lifelong. If it is a multiple sclerosis, treatment is immunomodulators you have to give, initially steroids followed by immunomodulators. So, any other doubts about this case? So, what is in the getting at a paraplegia case? First thing is it a spinal cord lesion or is it a central lesion? Then, if it is a spinal cord lesion, again, is it a spinal cord or is it a GB syndrome? If GB syndrome, its element features, bladder involvement, sensory will not be there. Again, the diagnostic criteria, it will know where it comes. So, if there is a cord involvement is there, next question is that, is it a compressive, is non-compressive? What are the features suggestive of compressive? Asymmetry, backache, root pain, bladder and bowel involvement later. Whereas non-compressive, bladder involvement will be there, symmetrical, progression. Again, progression depends on the etiology. If it is acute, you have to think of transverse myelitis. If it is a chronic progressive without any proper level, subacute combined degeneration. And again, patient is retropositive individual. HTLV1, then retroviral related directly. Cryptococcosis. It's called cryptococcosis. It's a mass lesion.
HIV myelopathy.
It's called vacuolar myelopathy. Again, thoracic cord is common in vacuolar myelopathy. Patient can present as a slowly progressive. Okay, so vacuolar myelopathy. If the patient has a predominantly lower limb, CMV can be there. Okay, so compressive, non-compressive. If it is a compressive, it comes is a intradural, extradural. Extradural compression, tumor, trauma, abscess. Okay, so next is intramedullary. How do you differentiate severe radicular pain, asymmetry, radicular pain, local tenderness, okay, bladder and bowel involvement late. Intramedullary, again, cauda equina comes in the lower part. Here it is a thoracic. Cauda equina and conus. Cauda is typically radicular pain, asymmetry, severe wasting, absent reflexes, bowel and bladder later. Whereas conus, symmetrical, early bladder and bowel involvement, loss of distinct saddle station. Okay, so when you got a paraplegia, you have to first ask, is it a UMN or LMN? Next comes the UMN, if it is there, is it most probably spinal cord? So is it a spinal cord? Then again, is it a compressive, non-compressive? If it is a compressive, within the compression from outside or inside, there is intramedullary. Intramedullary means only two things, empedema or this. Okay, yes. Any doubts are there? Or we'll have coffee break. Okay. Thank you for good presentation. And I didn't have much time to prepare. So, anyway, I could not examine the patient. Coffee break. Again, this again depends on the level.
ಕಾಫಿ ಇದೆ,
and you are seeing only pyramidal cells across the area. Initially, it's there, another shock will come, they will never survive. They are presenting with case the session is this. ಈ ವಾರದ ಸ್ವಲ್ಪ ಶುರುವಾಗಿ ಎಷ್ಟು ವರ್ಷ ಯಾರು ನೋಡ್ತೀವಿ You are all final years.
Second year.
Second years are posted in their very good. DRP. Very means nephrology, cardiology, urology, rheumatology. Cardio one, urology. And full 1 year is periphery, 8 to 9 months. Shortage of teachers. Other explanation for the edema it could be autonomic dysfunction itself. Probably it's a lupus because it's not edema. Lupus nephritis. It must be active only. And I is the drusen bodies you get understood. So drusen bodies patients do not get that. And the cystoid vascular pressure. You can get the active vasculitis. You can get this. Let's see what's different, no? This is yours, sir. I got my stethoscope. It's both ways. Start.
How come you are knowing that I am standing here?
So, we'll proceed to the second case. I think the abdomen case you would have seen many. Probably liver disease is so common. It's where they walk only you can make a diagnosis. Okay, but okay, you can present that.
Good afternoon. 45 May,
You can start.
45 May, occupation of security guard from Mysore, Cambridge chief complaints of yellowish discoloration of eyes since 14 days, abdominal distension since 14 days, bilateral overlap swelling since 10 days, and complaints of breathlessness since 8 days. Choking. Patient was in his usual state of health 2 weeks ago. When he was
Okay.
Patient was in his usual state of health 2 weeks ago when he developed yellowish discoloration of eyes, which was noticed by his family members. He also noticed high-colored urine and yellowish discoloration of skin around the same time. For these complaints, patient went to local Ayurvedic clinic and took some medication for 2 days, post which his symptoms got aggravated. Patient developed generalized abdominal distension, which was insidious in onset, gradually progressive to present state, which is not associated with abdominal pain or difficulty in passing fetus or stools. Patient later developed swelling of both lower limbs up to knee, which was persistent throughout the day, and there was no relieving factors. There was no associated pain or redness of lower limbs. Patient also developed scrotal swelling. Patient developed where no patient complains of breathlessness on minimal physical activity and aggravated with increased abdominal distension and relieved in sitting upright, with no associated history of cough or chest pain. There was history of fever 8 days back, which was high grade, not associated with chills, and not related by medication. No history of abdominal pain, no symptom.
The presenting complaint is abdominal distension, jaundice occurring simultaneously. Okay, 14 days. 2 weeks of yellowish discoloration, abdominal distension, then 10 days of pedal edema, and then 8 days of breathlessness. Okay. With this symptom, can you say which system is involved?
Liver.
Probably related to hepatobiliary or abdomen. Okay. So, what is little odd in this is that abdominal distension 15 days together. So, usually patient will have abdominal distension earlier than the time, and then they develop jaundice. Okay. So, in this case, is little odd. Okay. And lower limb swelling and breathlessness is 8 days. Okay. So, you proceed with the history. Past history, anything?
No, sir.
Okay, no. You told that he took a Ayurvedic medicine and it aggravated jaundice or abdominal distension?
Both, sir.
Both. Okay, yes. And then medicine for 2 days, which seems his symptom got aggravated in the form of this. Okay. So, anything else in the past negative before going to negative history?
No, sir.
Okay. History of jaundice is a very important history. So, history of jaundice for 2 weeks. Okay. If there's only jaundice, most common cause is what?
Only jaundice.
Only jaundice. It's hepatitis. Okay. If the patient doesn't have a fever, okay, usually patient has got viral hepatitis, they won't have fever at the time of jaundice. Most of the time, fever will be preceding 1 or 2 days before, mild fever, myalgia, which subsides. Patient develops jaundice, he comes to the hospital, and some anorexia will be there. So that is a typical feature. Or alcoholic develops a distaste for alcohol or smoking, then comes to the hospital. That is a typical viral hepatitis. Whereas patient in this patient, he has got a fever after 8 days, according to you. If the patient has got a fever and jaundice together, presentation, what are the common causes?
Alcoholic hepatitis.
First, you should not think of alcoholic hepatitis. Fever and jaundice, not leaving the abdominal distension. I am asking fever and jaundice together. Viral hepatitis, fever will be preceding.
Leptospirosis.
In a tropical country, most common is a leptospirosis and malaria. Malaria can cause jaundice. What is the mechanism of jaundice in malaria? Hemolysis in a vivax and other things. But falciform liver, it can involve the liver. Falciform hepatopathy is known. Patient can have a severe jaundice. Falciform malaria should be important differential diagnosis in the tropical country. Next is leptospirosis, particularly during the rainy season. Anybody comes with the agriculturist, fever and jaundice. Third thing is a dengue hepatitis. Usually hepatitis can occur, but jaundice is not common feature. Next. Scrub typhus. Again, scrub typhus commonly fever, respiratory involvement, breathlessness can involve the liver, but jaundice is not common. Another tropical illness which can present with the jaundice is what? Jaundice is not a common feature. Enteric fever can have hepatitis. Then other than these things, whenever a patient has got a fever and jaundice together, gram-negative septicemia, multi-organ involvement. It could be involvement of the liver, septicemia together with patient can have a liver involvement. Or patient has got a fever, hypotension, can have ischemic hepatitis presenting with jaundice. In this patient here, in addition, abdominal distension. Abdominal distension as such indicates what? In a patient like this. Jaundice, abdominal distension, it indicates liver disease. Then abdominal distension is due to
Decompensation of
decompensation, correct. But it's ascites is due to portal hypertension. It's the most important is portal hypertension. Again, portal hypertension, ascites. Jaundice is there. These two things suggest that patient has got a decompensation. Can it occur together in acute liver disease also? Yeah, it's acute fulminant hepatic failure can present it. Okay, acute fulminant. The patient has got no previous past history looking at without that. ACLF, patient can have a jaundice, ascites. One more important feature of acute fulminant hepatitis is
coagulopathy and
coagulopathy, encephalopathy. Okay, so you define fulminant hepatic failure based on the onset of jaundice to encephalopathy. If it is less than 2 weeks, it's acute fulminant hepatic failure. What is the common cause of acute fulminant hepatic failure? Most common can be in a UK and all paracetamol. In India, Ayurvedic medicines, particularly not common here. It's a slimming drugs and all those things. But more common here. ATT can cause, again, not very common. Ratol poisoning, not rat poisoning, ratol poisoning. Okay, ratol poisoning, it's a zinc phosphide which can cause fulminant hepatic failure, which commonly patient presents with jaundice. You will not have any history. Then you take the history, patient has taken ratol to commit suicide or something, which we have cases like that. Ratol poisoning can present acute. So anything else? One is a why infections as I told, leptospirosis can cause hepatic failure with the renal failure. What is it called? Wheel syndrome, it's very common presentation in our hospital. Scrub typhus, malaria can present with sepsis, malarial sepsis, particularly falciparum. Viral hepatitis, normally fever and hepatitis doesn't occur, but if the patient has gone to Ayurveda or something else, he must have got secondary infection possible. Enteric fever can have that. Infections like these three, tropical illness and gram-negative sepsis. After the infection, you should consider most important, as I told, alcoholic hepatitis. Alcoholic hepatitis, they can have a fever, they can have underlying liver disease, bout of alcohol. It could have caused alcoholic hepatitis, worsening, and ascites. Okay, next, toxins. Like as I told, this and aflatoxin may be possible. Then drugs like ACT in this thing, and post-operative period, halothin anesthesia can cause fulminant hepatic failure. Then what are the other things which you have to think? Vascular, what is it? Acute vascular insufficiency to the liver. Budd-Chiari syndrome. Okay, Budd-Chiari syndrome usually can present with the severe abdominal pain, enlarged liver, jaundice, patient can have ascites, fulminant hepatic failure. Okay, then infections, inflammation. What is the inflammation? Just now we discussed the case of SLE. Autoimmune hepatitis. Usually it's a chronic illness where the patient hepatitis doesn't improve, but in the patient it sometimes can present as a fulminant hepatitis. Okay, SLE or autoimmune diseases. Toxins, vascular insufficiency, particularly Budd-Chiari syndrome, or it could be fulminant septic or cardiac shock causing the decreased blood distinct to liver. So it can cause permanent hepatic failure. So you have to consider vascular, toxins, infection, inflammatory, and sepsis remains the first cause when you have got less than 2 weeks. Very commonly, which you can treat it. Rarely, patients who are immunocompromised, herpes simplex, cytomegalovirus, Epstein-Barr virus. These things can present with the hepatitis, permanent hepatitis. So these things should be considered in the patients like SLE or corticosteroids or autoimmune suppressives, or patients is HIV, or patients is some corticosteroid for something, because when they go to Ayurveda, they must have given some medication. It could have been this thing. Okay, so it's possible. Okay, so in this patient, and again developed a fever later. Fever at the onset with the abdominal distension patient, worsening of fever, worsening of with the abdominal fever. What do you suspect?
SPP.
Most commonly, patient has got underlying chronic fever disease. Infection is there. It's called spontaneous bacterioperitonitis. Patient can have worsening of the jaundice, can come this thing. Or patient has got a previous liver disease, can come with the pain, means either some infection, particularly SPP, or can come with the secondary infection, something else. So this patient had developed fever 8 days later. Okay, next.
No history of abdominal.
And the history of jaundice, what are the other things you have to? The patient had yellowish discoloration, correct? What are the other things which you have to ask in the history?
Like stool color, urine.
Itching. Pruritus is there, it indicates a obstruction. Okay. Obstruction, again, what is Charcot strand? Pain abdomen, fever, spiking fever, and jaundice. This is called Charcot strand. It is indicates a cholangitis, ascending cholangitis. It's a surgical emergency. So there may be stone or this thing. There is a pentad also. What is that called? Reynolds pentad. What are the two things? Altered mental status and renal failure. I think. Okay, renal failure. So that is again possible in the patient with the liver disease. So Charcot strand, if the patient has got fever, high-grade fever, chills and rigors, followed by pain abdomen and this thing, we have to think of these things. Okay. Then itching is important. Then stool color. Usually in the obstructive jaundice, there will be
clay color.
Okay. Yes, clay color. Yes, here the fever is next part. Patient has got abdominal distance. Only unusual is that 15 days abdominal distension has worsened with the jaundice. So, is there any precipitating factor? Was there a past history? Is important. Okay, yes. Or he has taken some acute alcoholic insult. Yes. Okay, he has got significant ascites. Okay, yes. Yes.
You continue. Yes.
No history of abdominal pain, nausea, vomiting, albeit diabetic, no history of
He is also very consistent, saying that only 2 weeks. Because most of the time, abdomen is big, maybe normal. For a particularly COPD patient, cough is normal. So when it becomes worsen only, they will realize. Okay. So liver disease patient, they may be having abdominal disease earlier, probably they would have not considered. Again, alcoholics can have what is called pseudo Cushing's abdominal hump. You must be knowing that. There's a differential diagnosis for pseudo Cushing's syndrome.
hematomas or blood scarring, no history of palpitations, orthopnea or PND, no history of facial puffiness, decreased urine or the urine, no history of IV drug abuse or recent transfusions, no history of easy bruising and bleeding gums, no history of tingling sensation or numbness over extremities, no history of altered sensorium, irrelevant of and involuntary movements, no history of surgery of high-risk behavior, no history of ulcer or discharge from external genitalia.
Why did you ask discharge from external genitalia?
So STDs, fluid STDs.
Okay. High risk behavior?
Hepatitis B.
Hepatitis B and C. Okay. So whenever a patient has got liver disease, two chronic these things you have to rule out, hepatitis B and C and associated retroviral disease. Okay. Yes.
No history of altered sensorium, irrelevant of involuntary movements, no history of drug exposure or medication intake. Patient is not a known case of type 2 diabetes, hypertension, IHD.
The history of diabetes is very important nowadays. Alcoholic, yes. Metabolic associated steatohepatitis is becoming increasing each day. Okay, yes. Presentation is not so acute. Yeah, so acute is not common. Okay, yeah.
Not a known case of IHD, hypothyroid, CVA, seizure, disorder, or renal disorder.
Why seizure disorder?
Wilson's disease.
Okay, so usually Wilson's when you suspect.
Like involuntary
Young age of onset of liver disease, involvement of neurological, what type of neurological involvement? Usually it's extrapyramidal, okay, not the seizures. It is usually Parkinson, young jaundice. You have to and the family history. It's not the seizures, okay, it's a patient has got a young Parkinson's feature or patient has got a young unexplained liver disease, Wilson's disease, ruled out, okay. And hypothyroidism. Hypothyroidism can it cause liver involvement? Hyperthyroidism can it cause liver involvement? Particularly, neomercazole and propylthiouracil are known to be hepatitis. It can cause. Hypothyroidism can involve the liver. Associated autoimmune disease, if it is associated. Okay, diabetes, we know. Hypertension, seizures, anything else, anti-epileptic medicine which can cause liver disease. Phenytoin can cause. Sodium valproate can cause fulminant hepatic failure. When you start sodium valproate, you have to tell the patient this. Okay, just next. Renal disorder, we told what is the renal disorder, what did you mean?
Patient edema, nephrotic syndrome.
Okay, in this patient, no other differential diagnosis comes. It's a liver disease. Yes, renal disease. Can it involve the jaundice? Or other aspect is a hepatorenal presentation together. What is that? I already told. Acutely in a Wilson disease. Or it can be multi-system involvement like SLE. Or it can be drug damage causing the both liver and kidneys involved. Okay, yes.
Past history, no history of similar complaints in the past.
You never had a history, yeah? No. They didn't go through your history because it was yes.
No history of any prior hospital.
First time, yes.
First time.
Oh, yes.
No history of any prior hospital admissions. No history of any surgeries in the past.
Okay, no history of surgeries in the past. Okay.
Personal history, patient consumes mixed diet, predominantly non-vegetarian. He has disturbed sleep since 2 weeks in the form of reverse sleep-wake cycle and increased daytime sleepiness since 10 days. Patient has decreased appetite since 1 month. and history of decreased libido. A patient with a chronic
That when you, how long is there in the decreased libido?
Sir, since 1 month.
1 month. Abdominal distension surely to 2 weeks.
Yes, sir, 2 weeks. And patient is a chronic alcoholic since 10 years, and he consumes about 180 ml per day of liquor. He is a non-smoker.
Okay, what type of alcohol? Because in the history of alcohol is there. Ideally, you should ask what kind of alcohol. Because 180 ml, if it is a beer, contains how much alcohol?
1%.
1%.
5%.
5 to 7%. Okay. So 5 to 7% means it's about 7 grams. 180 ml of a beer is about only 10 equal to this thing. Okay, it's 1 or 2 drinks. That's all. So if it is a hard liquor, okay,
40%.
40% is whiskey and brandy. We should know the contents of this thing. Okay, then ladies drink. What is ladies drink? Gin. How much it contains? How much it contains? It's about 20%. Okay. Wine. How much it contains?
40%. So 22%.
Wine. No, red wine is not there. Okay. 10 to 15%, not much. Okay. Whereas vodka, about 32%. Rum. Okay. So I don't drink alcohol, but I got a lot of alcoholic friends. So many of friends, I get some information. Okay. And again, country liquor, spirit is contained up to 80%. Okay. So each drink, okay, why you want to know is that he's drinking for about 10 years. So what is cirrhotic dose of alcohol? If you say it's cirrhosis, I will come to that. Okay, let him put.
Male 40 to 80 grams, sir. Female 40 grams, and we should take 40 to 80 grams per day for 15 years.
Okay, it's about 60 grams, at least 4 to 6 to 8. This thing for a steady drinking is more important for a period of 10 years. Okay, but all those who drink that much will develop cirrhosis.
No, sir.
Only less than 5% will develop. Why? What are the other factors which make this?
Alcohol dehydration.
Okay, one, genetic predisposition. Third thing is associated hepatitis C and other hepatotoxins. Okay. Again, in Western world, they have found that hepatitis C and alcoholic liver disease is more commonly associated. And again, females that alcohol dehydrogenase, this thing is less. So content of alcohol, 40 grams of alcohol is sufficient and lesser duration. which has worsened. Okay, how do you know by history? Can you know by the history? I asked him, he didn't tell. History of previous ascites, previous pedal edema, which has taken treatment. Some diuretic would have caused decrease in this thing. So previous history of black stools or hematomesis. Typically, variceal bleed presents as a typical history is what? Painless massive blood. First time you find that patient has come with a painless, this thing is a typical. Otherwise, they come with ascites. Okay. Cirrhosis normally presents with what? Either, yes. Huh? No. Cirrhosis usually is a liver is a big organ. It's the biggest internal organ. It has got great capacity. Either it presents as a when the degeneration regions and portal hypertension occur, because portal blood supply is the main. So either they come with the portal hypertension or come with the synthetic function of liver goes with the pedal edema or coagulopathy. Or liver has got such a preservative, patient can have a compensated liver disease going on, cirrhosis, going on for some time. Then some insult. What are the common traditional insults are? Alcohol, hepatotoxic drugs, virus, any in fever or causing secondary things, or patient has got some, even we may not say, but any already asset is SBP, or GI bleed, or infection. Any other factors which can come as acutely? Worsening of the liver disease. Those known liver disease. Here is a little unusual here. Patient has got ascites, mild or something, treated all right. Okay. When this patient is on medication, somebody would have given him diuretics, he was already ascites is okay, or this. Second thing is that portal vein thrombosis. The patient with the liver disease, portal vein, is the bleeding more common in the liver disease or thrombosis is common?
Both are common.
Both are common. That's the wrong concept you have got is a bleeding from the varices is common. Actually, many times they can have a thrombosis because anticoagulant factors are also synthesized in the liver. It's a balance between thrombosis and the bleeding. Some patients, most of the time what we see is a bleeding because immediately they come. If the patient has got thrombosis, what will happen? Patient can have portal vein, which is the most common site for thrombosis. Patient will have increased portal hypertension, ascites, pain abdomen, which may be neglected. When the patient vomits a blood or passes a melena and develops anemia, they will immediately come to the hospital. So both are equally common, thrombosis and bleeding. Last one is a patient is compensated, everything, there's sometimes new onset of HCC. If suddenly somebody comes, is already liver disease is there, which probably is not noted. Other than that, as I told, any hepatotoxic, it could be ayurvedic medicines, or it could be another toxin, or it could be small infection. They could have decompensation. Small infection, particularly liver hepatitis. Hepatitis A would not have caused much problem for a young man. Patient is alcoholic, he can get decompensation. So, in the patient, some other infections which can involve the liver, or sepsis involves the liver, they can come with a decompensation. Okay, what did you think in this patient?
First thing regarding
Alcoholic hepatitis. As I told, alcoholic hepatitis typically presents with fever, abdominal pain, jaundice. Ascites is it so common? I have already told it. Usually, 20% of them have already got cirrhosis. With alcoholic hepatitis, they can come with this. Otherwise, first time alcoholic hepatitis, they may not have such a gross ascites. And pedal edema is due to what here? Cross activation, hypoalbuminemia. Means the synthetic liver function is gone. Okay. Only thing is that he didn't have a bleeding manifestation and hepatic encephalopathy. These two things are not there. Otherwise, he had a decompensation forms in the form of ascites and portal hypertension there and pedal edema. Okay. So portal hypertension, ascites could be contributed by hypoalbuminemia, but mostly it is due to portal hypertension. Okay, RAS activation, salted water retention can occur, but it's usually predominantly hypoalbuminemia. Okay, so alcoholic hepatitis, is it a viral hepatitis? How many of you agree that it's a viral hepatitis? What do you think? Which viral hepatitis is there?
Can be aggravated.
Huh?
Underlying cirrhosis was aggravated by viral illness.
Okay, that's what I'm telling. Patient has got compensatory liver disease, probably because he has already taken sufficient C2H5OH, we say C2H5OH. So probably some viral hepatitis could be there. Hepatitis A, E. Is it B, C?
No, sir.
Possible? B, C? Could be possible. Okay. Huh? No. What does the B and C present is? Usually B presents as a definite history of if there is a parental or a sexual history is there, or needle injury or this thing. C usually doesn't present as acute hepatitis. It's usually chronic, usually related to transfusion or earlier parental injection, hepatitis C. Okay, sexual transmission is also not much common. Next is hepatitis E. Again, orophycal route. Again, normal people it cannot cause much problem. Only in pregnant ladies and extreme suffering or underlying liver disease. Those who have got already underlying liver disease can happen. When you see viral hepatitis, these are called hepatotropic virus. Hepatitis A, B, C. D is usually either co-infection or super-infection. So, if you have got hepatitis B, co-infection can cause what is called aggravation. Okay, that is fair. Okay, those who got still. The D can become there. Okay. Next is non-hepatotropic viruses. There are so many non-hepatotropic viruses. What are those? I already Epstein-Barr virus, CMV, herpes simplex, HIV. So all these things can involve this. Okay. So why you not put bacterial? Only viral hepatitis here. Bacterial, as I told, leptospirosis, multi-organ problems, leptospirosis, enteric fever. Yes. So again, rarely they can present as a this thing. Okay. Decompensation secondary to so which likely first, second, third. You have put first as alcoholic hepatitis. Is it a typical alcoholic? His fever is only few days. Usually alcoholic hepatitis causing fulminant this thing presenting like this is little unusual. I feel that known cases, but when you say chronic liver disease, you should have history of for 6 months. It's not there. But what could be missing is his lab reports or some symptoms with a previous history. He has never shown to a doctor.
No, sir.
ಇದ್ರ ಮುಂಚೆ ಯಾವಾಗಲೂ ಡಾಕ್ಟರ್ ಹತ್ರ ಹೋಗಿಲ್ವಾ ನೀವು? Oh, he's sleeping. So he's a classical example of daytime sleepiness. I tell my undergraduate students, classical example of hepatic insufficiency is when I take class at 8 o'clock, most of the students will be sleeping. Evening when they go, they will be fully awake. Okay, 8 o'clock classes are the most difficult classes. Okay, yes. So he's sleeping. So he's in encephalopathy. Okay, so he told no encephalopathy. You told that no features of encephalopathy, no? He's there. Okay. I thought he's not in encephalopathy. Okay. Anyway, he's sleeping. ಮುಂಚೆ ಯಾವಾಗಲಾರ ಜಾಂಡಿಸ್ ಆಗಿತ್ತಾ? ಯಾವಾಗಲೂ ಆಗಿಲ್ಲ. ಮುಂಚೆ ನಾನು ಆಯುರ್ವೇದಿಕ್ ಮಾತ್ರೆ ಏನೋ ತಗೋತಿದ್ದೆ ಸುಸ್ತು ಅಂತ. ಜ್ವರ ಬಂದಿದ್ದೀಗ ಅಷ್ಟೇ ಒಂದೇ ದಿನ ಜ್ವರ ಬಂದ್ಮೇಲೆ ಜಾಂಡಿಸ್ ಬಂತ. ಜ್ವರ ಬಂದ್ಮೇಲೆ ಜಾಂಡಿಸ್. ಜ್ವರ ಬಂದ ಜಾಂಡಿಸ್ ಆದ್ಮೇಲೆ ಜ್ವರ. So next, okay, yes. So as you told, it order may be correct. Alcoholic hepatitis could be the first possibility, or you should take hepatitis, fulminant hepatitis, which can A, B, C, D, E, which can cause fulminant hepatitis. E can occur in the pregnancy. A can occur fulminant hepatitis, usually self-limiting. Rarely with the underlying disease can go. Hepatitis B, if it is transmitted to the mother to the fetus, sometimes can be. Okay, yes. C, usually no acute, but it's usually chronic. Yes.
Example. Yeah. Patient is conscious, cooperative, and oriented to time, place, and person. Patient is well built, height 168 centimeters.
Again, is well built.
Sir,
Patient is things are again one more thing is that when you got a cirrhosis, alcohol, Alcoholics can be never well nourished. Built is okay because they can have the height and this. And again, rich people can be heavy alcoholics. Built can be positive, no problem. But nourishment, alcoholics have got. If you say alcoholic, when you say alcoholic, that you didn't tell. He's alcoholic. You told. What is this thing you use? It's called cage scoring. Okay, there is alcohol dependence, alcohol abuse. What is alcohol? CAG, cage scoring. Okay, can anytime you felt cutting down to this thing, annoyed by this thing, guilt, IO. Okay, morning to this thing. Okay, so whereas alcohol abuse, what is alcohol abuse? Disturbing family and personal and family. What is that? Professional life. So if somebody has to leave the job. Okay, there is otherwise it's a social drink of alcohol. Okay, yes, well built because of the height and weight you told, or what is it? Height 168 is what? Is it normal for Indian? I am also 165, 166. Okay, it's a normal male, normal Indian male. Weight is 92. It's partly due to ascites and penile edema. BMI is high, so it's due to you can't take the BMI part. Okay. Next.
Pallor present, sir. Icterus present. Sclera subluminal.
What is the grade of the icterus here? Mild, moderate, severe.
Severe.
He is deeply icterus. Go near him is deeply icterus. Even the skin may be this thing. Okay. Yeah. So at least his bilirubin may be near 20, I feel. Okay, looking at him. Okay. Yes. He is deeply jaundiced. Okay. Where do you get the highest level of bilirubin? Conjugate obstruction or obstruction will be high, but extremely high will be again hepatocellular fluid, more than 45, 50. Okay, yes. Usually, normal hepatocellular will be 5 to 10, 15. Yes. Okay. Next will be higher, it will be obstruction. Obstruction, particularly biliary obstruction due to stone, carcinoma, all surgical causes. But extremely high level is a hepatic failure. Okay. Yes.
No cyanosis, clubbing, and lymphadenopathy. Tongue was bald and red with tinge of yellowish discoloration. Tinnitus is present in both eyes. Acanthosis nigricans over the nape of the neck. Skin tags.
Acanthosis over the nape of the neck is present. Okay, what does it indicate?
Insulin resistance.
Insulin resistance. Okay.
Skin tags around the neck and axilla present. Bilateral parotid swelling is.
What does the bilateral parotid swelling indicate?
Alcohol specific.
Okay, one is alcoholism causes a bilateral. What are the other causes of bilateral parotid swelling?
Sarcoidosis.
Sarcoidosis, mumps in acute condition,
TB.
Diabetes itself can cause. Diabetes can cause bilateral parotid swelling. Then sarcoid and all the sarcoid, hemophilia, overs, all those things can occur. Mumps, measles, mumps. Okay, then there's a single for one side, or can be bilateral. Sialoidinitis. Sialoidinitis usually you see bilateral, bilateral can occur. Diabetes, some other 2-3 causes. Okay, yes. But it's due to cirrhosis or is it due to alcohol? It's a etiology, alcohol. 2 marks, sir. Gynecomastia, your demo.
Yes.
What is that? What when you say gynecomastia, what does it indicate? What should be there to say gynecomastia? Both glandular and the areola, both should be in that. Okay, you should be palpating this thing. So and again, usually it will be. Yeah.
2.5.
Is it? You palpate this thing? Do you think he's got this thing? So glandular tissue also not appears to be much. Okay, so it may be just is fat or so obese and what happens to the breast in a female with cirrhosis? Yeah, in the males it will develop gynecomastia because it's a balance between testosterone. In women it's breast atrophy. Okay.
tattoo marks or marks present on the both forearms.
What does it in importance? Hepatitis. Which one? B, C. But more important is a C in a alcoholic liver disease. Next.
Shiny skin or the abdomen, no alopecia, fetal hepaticus.
What is fetal hepaticus?
Due to mercaptans, it can't be synthesized by the liver.
What is the classical smell? Dead mouse. Okay, dead. Okay. What are the other odors you can get in medicine? Fruity odor classically then ketoacidosis. Garlic odor where? Commonest is a OP poisoning which will have kerosene. Okay, then fishy odor, ammonical odor. Urine smell in a uranium. Almond smell in a cyanide poison. Okay, so fetal hepaticus is a dead mouse. That's how we are this. Yes.
No palmar eczema, depends on contracture, has to access spider neve.
You saw the spider neve is not there. Okay, huh? So again, spider neve indicates a permanent hepatic this thing. Okay, yes, more than 5 are there. Testicular atrophy is not there.
No.
You palpated the testis. Okay.
Vitals, pulse 88 beats per minute, regular in rhythm, normal in volume and character, no regular delay or femoral delay. All other peripheral pulses are felt.
So what pulse abnormality you can get in this cirrhosis? High volume, collapsing pulse. Sometimes it may look like a aortic regurgitation because intravascular volume expansion. You may get a collapsing classical pulse also in cirrhosis. It did not be present as always. Okay, one of the last causes of collapsing pulse.
Saturation 98% roommate, both sitting in supine position. Respiratory rate 22 beats per minute, thoraco-abdominal rate, JVP normal. Oral cavity, good hygiene, good oral hygiene, no ulcers, flush or cheilitis.
What is his job, you told?
Security guards. No fetal hepaticus and halitosis.
What else in the systemic examination, general examination you could have told? As a part of general examination, asterixis. Okay. So is he there?
No, sir.
It's not, could not get. Okay. Yeah, but is he in hepatic encephalopathy? Yes, he's in. So what test you do? You have to card test or you have to see the construction test. How do you test the flap in a lower? Yeah. If the patient hand will not be done, keep the both legs like wide apart, ask to shift wide apart. What happens is that it will start palpitating. Okay. So these things you can do it when the patient is lying down, not able to stretch this. In this patient with classical asterixis is not there. Okay, he is fully alert, not alert, he is sleeping, and we are talking also he is sleeping. So he is in hepatic encephalopathy. Okay, yes. What is the definition of hepatic encephalopathy?
Reversible brain dysfunction due to.
Is it always reversible? Most of the time, chronic liver disease is not reversible. Anybody wants to better definition? It's a neuropsychiatric syndrome characterized by either extreme aggressiveness or drowsiness to coma. Usually always due to hepatic dysfunction and portal systemic shunt. Either both should be there or one should be predominant. Hepatic dysfunction becomes very predominant in a chronic liver disease or acute fulminant hepatic failure. Portal systemic shunt becomes very important when the patient is portal hypertension. Plus, you do shunt surgery. Many of the shunt surgeries are stopped because of the development of hepatic encephalopathy. So it's a neuropsychiatric, it's a clinical diagnosis. It's a clinical diagnosis. In this patient, is he in hepatic encephalopathy? He is in hepatic encephalopathy. What is the grade?
Minimal of grade 1.
Minimal. Grade 1 is definitely there. We make him the chart and all, it may be good thing. Okay, many of these patients will continue to have a chronic hepatic encephalopathy. So you should treat them as a prevention. Okay, yes, next.
Systemic examination, inspection. Abdomen is uniformly distended, flanks appear full. Corresponding contents moving equally with respiration. Skin over the abdomen is shiny. Umbilicus is displaced upwards, appears black with transverse slit. Scars present over right lumbar and in the right iliac fossa. Stretch marks present over the flanks.
What does the stretch mark indicate? Okay, other than that, stretch marks are common in a Cushing syndrome or in pregnancy or corticosteroid this thing.
Yellowish discoloration of skin over the abdomen present, scratch marks seen over the abdomen, no divertification of recti, no paralysis.
Sure.
No paralysis mark. No
Yes, it has to be there. Okay. So I did not examine this thing. I can tell that is there. But see, such a ascites, he must be having a significant. Okay. See, let's up. So that's a divarication because such a site is, he definitely has got lot of fluid, but he has got fat. I don't know how much is the fat, how much is the ascites. See, these conditions, clinical examination they have limited. He's already obese, just developed ascites. Okay, yes. So there our limitation is there, ultrasound cremate. Yes, next.
No dilated veins, no visible pulsation.
No paracentesis marker of the blaster there.
No, sir. Recently we did, sir. Before 2 days.
Yesterday was.
Yes. No dilated veins, no visible pulsations or visible peristalsis. Palpation, superficial palpation, no tenderness, guarding and rigidity, no local rise of temperature. Deep palpation, abdominal girth 1 to 2 centimeters, from xipisternum to umbilicus 29, and umbilicus to pubic symphysis 17 centimeters, left spino-umbilical distance 25, and right spino-umbilical distance 25 centimeters. No hepatomegaly, spleen is not palpable.
Medically, no hepatomegaly. You palpated, no. What spleen is not palpable. Sure. Did you use what are the other methods you used? Patient has such a ascites. No other palpable. Okay. So he's clinical. Continue.
Auscultation, bowel sounds weird, entombing, no arterial body or venous hum.
No dilated veins also. Not there. Are you sure?
Yes, sir.
You have to make the patient
And
such a gross ascites and deep jaundice, I find it very difficult to believe that. There are some dilated veins, but not what you say grossly tortuous and dilated. Not visible. Okay. Yes. Some are there, few are there. Yes. I will be surprised that he doesn't have photo.
external genitalia, scrotal swelling present, testicular atrophy is present, no loss of pubic hair is present. Other systems.
Means secondary sexual characters observed.
Yes.
No baby, no accident.
Yes.
Okay. Yes.
Other systems, CVS, S1, S2, and ESM present in pulmonary.
Okay, you got breathlessness but no prolifation. No prolifation. So in this patient, we expect a ascites is there. So shifting dullness is there. No?
Yes, sir. Both shifting. Both are there.
Okay. So what is this cause of this breathlessness? What will be the feature in the hepatopulmonary syndrome?
Patient
What is classic?
orthodox.
The dyspnea orthodox. When they lie down, they get
Comfortable.
When they sit up, opening of the
Breathless.
this thing due to nitric oxide, so they will get breathless typically. And in this patient, it's grossly breathlessness, maybe secondary to ascites. The expected prolifation, I am also not getting clinically prolifation. Okay,
CNS, higher motor functions are normal.
heart is not good.
Yes, sir. Cranial nerves are normal. Motor system, normal power, 5 by 5.5 volumes. DTRs 2+. Bilateral planters of flexor. Sensory.
Minor planters are flexor.
Yes.
In this patient, you know flexus, flexor is absent. You did the chart.
Yes, sir.
So the star.
And number 20. No sense of.
Can you say is in the ventricle?
Yes.
Is clinically minimal hepatic infarction.
No tremors, no asphyxis, conceptual is not. Final diagnosis, decompensating chronic liver disease, portal hypertension, and grade 1 hepatic encephalopathy, secondary to chronic ethanol consumption, with no evidence of upper or lower GMB.
So your diagnosis is a decompensated chronic liver disease. So how do you make it here in this patient chronic liver disease? Because history is 15 days. According to you, there is no dilated vein. How did you say portal hypertension? The portal hypertension is different. size of your cell is failure. Portal hypertension is due to decompensation possibilities. So what are the signs of portal hypertension? The most important sign of blood portal is splenomegaly. Okay. Second thing is ascites. Third thing is esophageal varices. Dilated veins. We get classical. Dilated veins, but again dilated veins occurring within the apical intestine. Esophagus is a varices which you have to do the endoscopy to see. So out of this, he has got only according to ascites. Okay. So decompensated. What is the sign of decompensation? Jaundice, ascites. Two things are definitely there, and edema is also there. He has got a decompensation. Why did he say chronic liver disease? Liver cell, is it hepatocellular failure? There are two questions comes. Is it a acute liver disease? Is it a chronic liver disease? Here history is 15 days, no history of past. So that's why I started. It looks like for me, he has got a chronic liver disease, which was unmasked by some acute infection. What could have been the alcohol thing? That's what I brought. Alcoholic hepatitis, already 20% have got underlying alcohol base. When the cirrhosis is there already, and the alcohol can push them into decompensation. So 20% have already got. So if this patient comes in that category. Otherwise, history of chronic liver disease will be history of ascites, jaundice, which has this. Usually, once the decompensation occurs, overall long-term survival comes down to 2 to 3 years. So usually they will come to the hospital with a deep jaundice. It would have been 2 or 3 admissions there. Okay. So what type of grade 1 hepatic encephalopathy? Secondary to the grade 1 hepatic encephalopathy based on the
Sleep with
history. Okay. Secondary to chronic ethanol consumption with no evidence of. Okay. No varices. Spontaneous bacteria is there or not there?
no, sir. No.
Okay. So urine output is normal.
Normal.
Okay. So now you have to show that how did you prove that this is a chronic liver disease? How do you say it's chronic liver disease? What are the investigation you want to?
Like,
Any investigations available? No. So you what investigation you want to tell in order of to say that you are diagnosed decompensated chronic liver disease. You are first diagnosed decompensated. So what is the liver test you do first? Liver function test. Okay. What you want to see in there? First is bilirubin, AST, ALT, and albumin. Do you have anybody has a report? Okay, albumin is very important here because if he's got a 15 days history, albumin should be normal because it's usually half-life is a 4 to 6 weeks. So the albumin is normal, but again albumin can go low if there is an acute phase reaction. Okay. So next question is in PTIN. So PTIN can vary in a patient with acute liver disease, also in a chronic liver disease. So in this patient, how do you say it's a chronic liver disease? Platelets can be low in a chronic liver disease. But acute liver disease, does it cause low platelet? If there is a sepsis or something, it can occur. Yes, next. So, yeah, read the investigation.
Yeah, PTN, sir. PT 24.3, INR 2, and AP.
INR is 2. Means he has got a already. Okay, then. Bilirubin?
Bilirubin 15.3, sir.
Yeah, it's around 15 clinically. Okay,
And direct 13.1.
Okay, it's a conjugated. Okay, next.
AST 38 and ALT 46.
AST, ALT 38 and 46. Is it acute liver disease? Okay, what happens to the AST, ALT liver disease? Chronic liver acute to this thing?
Specific to liver?
AST, ALT can be normal in cirrhosis. Only if the patient develops acute, ALT can go, and when the fulminant of liver failure is there, liver ALT can become normal. So what is normal ALT for a male and female? Anybody wants to tell? One male can tell, one female can tell. Male, what is normal? 40. It's not 40, it's the 32. Okay. So when it becomes 64, it's already twofold elevated, particularly for treating hepatitis B and C. For a female, normal is not how much? Huh? No. For a female, normal ALT is 90. Our labs give different, but if you see standard textbook, 19 for a female. When it becomes 60, it is already 340. Because this is very important to pick up early metabolic associated steroid. So normal for a female is up to 19, for a male up to 32. Again, in a liver alcoholic hepatitis, AST, ALT will be elevated. It will be in the range of
AST more than
AST will be more than the ALT. Why?
because ALT requires iron phosphate.
It will be inhibited in the alcoholism. Okay, AST, ALT will be elevated, but it will be in the range of 150, 200, 300. So here that AST, ALT is also not elevated. So is it alcoholic hepatitis? Is not. Okay, it's not already. Okay, yes. Next, what is albumin?
2.1, sir.
Albumin is 2.1. So I most probably has got a chronic liver disease. Okay, PTA analysis. Okay, next, what are the other investigations available? ALP. ALP is important in this patient. Why? Cholestatic. Okay, so his jaundice looks very deep. So is it in permanent hepatic failure or this thing? In a alcoholic, that's a what is that? Hepatitis is a steatohepatitis. So ALP can be elevated with the itching mark. How much is the ALP?
So 125, sir.
So normal is again normal. Okay, so yes, next. So what are the other things you would look for the investigation? Ultrasound abdomen.
Sir, USG showed chronic parenchymal liver disease with future suggestive of portal hypertension.
Okay, how do you say in the ultrasound?
Portal vein will be more than 12.
So most important is it's a observer dependent. Okay, liver size, what do you expect? Small and shrunken. Okay, but liver in this patient is clinically not palpable. You have to do the percussionist liver upper and lower. Okay, whereas it's observer dependent liver echogenicity. But again, now we have got a better investigative model called fibrosis, which can directly give you the measurement. And the portal vein more than 12 millimeter distance. Okay. Next is most important is ascites and spleen. Is there?
No, sir, no splenomegaly.
In ultrasound?
Yes, ultrasound spleen 14 centimeters.
14 centimeters up to 9 or 11, 9 to 11. So 14 is slightly in that, it's not very this thing. Okay, what about ascites? Gross ascites?
Yes, gross ascites.
Okay. So now how do you proceed now? So you got a confusion here. One is it acute liver disease or is it a chronic liver disease? Why has got such a high bilirubin? Okay, high bilirubin, albumin is too. Definitely has got chronic liver disease. Why has got and doesn't have hepatitis? Okay, what are the things you do next?
Next, upper GI endoscopy.
Before that, ascitic fluid and look for a
high sag or low sag.
High sag. What is the sag here?
1.4.
Okay, high sag ascites. Okay, what happens if the what about cell count?
Cell count.
Lymphocytic predominant. Okay, so is it SBP? No, it should be neutrophil predominant. When you get a SPP, what happens to the sag in a cirrhotic? It will be still high sag. Okay, when you get a low sag, you have to suspect other than malignancy and tuberculosis. If it's a what you say lymphocytic, it has got a deep jaundice. ALP is grossly elevated. You can think of tuberculosis because we don't know what is this. Okay, so here there are two things contradicting. Okay, so is it a lymphocytic or is it a 200 cell? More than 250 cells is required to say SBP. Here again lymphocyte. So we don't know what is it correct or not. Next, what is the next most important investigation you want to ask? Alpha fetoprotein. Okay, what is normal? 4 is normal. When it becomes 8 or double, it has started already chance of HCC. What is the alpha fetoprotein?
3, sir.
3. So that's what 4 is up to 4 is okay. When it goes beyond, you have to suspect it. Next, what are the things? So we have to find out the cause of this decompensation. What are other things which you have to do? You have to look for hepatitis A, E. Definitely AE. You must have hepatitis infection which has subsided. Is already underlying liver. This has become more. Hepatitis A, E, B, C is required. Okay. And any other infections possible. And what is the cause of his fever? Fever in a cirrhotic. They can get an infection. Fever may not be there. Okay, but most common is SBP. And cirrhosis patients are prone for all kinds of infections. Most common is E. coli, abdominal, UTI. They can get a capsulated organism. Streptococcal pneumonia is more common. All these things can be occur. Any infections can occur. So patient fever is a warning. So he has got a fever means he may be having underlying infection which is not detected. Okay, that has to be looked at. Okay, so blood culture, urine culture, because signs of inflammation may not be manifest. So he may have a pneumonia, he may have urinary tract infection which has caused this worsening. So you have to treat aggressively with the covering gram-positive, gram-negative organisms. Okay, next. Any other investigation? How do you treat it? He has got a grass ascites, he has got portal hypertension, he has got a jaundice. How do you treat?
For ascites, we will prefer diuretic.
No, first is he has got a grass ascites, jaundice, fever. Now he is no AFib, right? Antibiotic after sending blood culture, you have to start. For ascites, tap the fluid, how much?
Large volume.
You can first your diagnostic you do, and he has got a grasses. I think he must be having 6 to 10 liters. So you may have to tap it to relieve his breathlessness. But when you tap too much, you may lead to hepatic encephalopathy. Yes, already in early this thing you should be given. But when you are tapping more than 2.5 liter, you may have to give albumin. When you give albumin, how much you can tap?
Sir, 1 liter, 8 grams of albumin should give.
Yeah. So when you give a 20% albumin, you get 8 grams, you can tap 1 liter. 2.5 liters you can tap. That's a simple conversion. So when you are tapping more than 2.5 liters, you need to give. Again, we use FFP. How do you convert? FFP is again a concentrated this thing. So 4 FFP means it will come to 20 grams or something. Then you can tap 2.5 liters like that. Say, so normal albumin is how much? Our body is 3.5. So you have to calculate 100 ml. 300 ml like that, so that you have to calculate and give. But usually FFP should not be used for all. Okay. Then do you want to give vitamin K?
Vitamin K.
This vitamin PTINR is prolonged.
Yes, sir. We should give, sir.
We should give. All of you agree? Not.
But no synthesis. What?
So that's a very controversial this thing. But any patient with the liver alcoholic hepatitis, you have to give vitamin K 3 days. Okay, it's given in Sheila Shadda. Why is that? You are giving it when you give a cirrhosis. What is that factor 2, 5, 7, 9, which are the synthetic factors are not there. You are meaning here synthetic factors is gone, but you are giving vitamin K. Why is that? Not peripheral. There is a cholestatic phase, particularly in alcohol. That amount of vitamin K is a fat soluble vitamin. So when you give vitamin K, it can be corrected. If there is a reversal, there is a significant cholestatic part. After 3 days, that doesn't change means it's a synthetic function of liver is gone. So for this reason, it's given in Sheila Sharlap in one paragraph. If you read, you have to read a book called Sheila Sharlap. She is one of the unfortunately, these are all what is called godmen or women of medicine. Sheila Sharlap is for liver disease. And yesterday, Dr. Brownwald, who is the father of modern cardiology expired. He was 96 years. So these people, whatever is there, at least try to see few chapters. Liver disease you can read from Sheila Sharlap, and coronary artery disease and the things from Brownwald. So as a postgraduate, you should read some standard books. One is Sheila Sharlap, one is Brownwald. There is a Williams testing endocrinology, but again diabetes, Jocelyn's neurology. Whatever the books is, this is neurology differential diagnosis by pattern that will give this thing. And Dijong is for examination. And then there's a to make a notes like calendar is the neurology, neurosurgery illustrated. He has given in a diagrammatic form. So this you should read. And for infectious disease, if you are interested, there's a Mandel's and Manschenberg books are there. For at least for cardiology, like a Brownwald, Sheila Sharlap is, and its book is very understandable. So in cirrhosis chapter is about, say about 50 pages. You should read the cirrhosis chapter in that page. Okay. Then, so vitamin K should be given. Now what about ascites? What diuretics you give?
Sir, we can give furosemide along with spironolactone.
Furosemide, is it a first choice? No. You should use a spironolactone because it's a secondary hyperaldosteronism. When the patient has such a grass ascites, you may use a what is called judicious use of loop diuretics. When you give a lot of loop diuretics, intravascular hypokalemia occurs, patient will develop hepatic encephalopathy. So it should be little slow. Give a doctor can go up. What is refractory ascites?
Like two things, sir. Two types of refractory: drug resistant and drug intractable. Drug resistance means up to maximum %.
Most of the time, what we mean is our side it's a drug resistant. Okay, huh? So spironolactone dosage of
400 mg, sir.
400 mg and loop diuretic
160 mg.
160 mg. If you are using it, patient continues to have this thing, you can consider as a resistant. But other one is a
drug intractable, sir. Like because of drugs, patient can worsen, so like hypokalemia.
Okay. So other than that, when you sometimes you don't get, last resort is use a thiazide diuretic. Thiazide diuretics. When you add with the loop diuretics, patient can have profound diuresis. First thing is that patient should have a bed rest. When the patient lies down, they will have a profound diuresis. Edema comes down, ascites comes down. Second thing is a salt restricted diet. That's the second thing. When you restrict the fluid.
Like in first stage, like mild ascites will be mild and moderate.
Anybody else? Okay. So salt restriction is more important than the fluid restriction. But when the patient has got persistently sodium below 125, so it indicates two things. One is a bad liver disease. What is the sodium? Second thing is that you have to restrict the salt also. So otherwise salt is not, fluid restriction. So sodium is one of the prognostic marker in liver disease. If the patient has got dilutional hypernatremia, sodium is persistently below 125, it's a poor prognostic marker. Otherwise you have got a prognostic markers like child book score, address score. Address score is important for alcoholic hepatitis. So is he having alcoholic hepatitis? Whatever your investigation is not suggestive. So address score, if it is more than 32, you have to give a steroid 40 milligram for a period of this thing. Otherwise, most of the time it is difficult to give because they have got an infection. You use a pentoxify. So there are also other alternatives are trying. Okay. Yes. Next, any other treatment you want to give for him? Is he a candidate for liver transplantation?
Depending on MELD score, we.
Okay, you have to give the MELD score staging, and most important is that he has to stop alcohol for at least 6 months to consider for intake. Okay. Yes. So and then you have to look for his renal function. All the hepatotoxic should be stopped. Okay. Anything else? And again, this patient should be on syrup. Hepatic encephalopathy treatment is what?
Lactulose.
Lactulose is the treatment. Rifaximin for a refractory hepatic encephalopathy. Okay. And these patients are already prone for infection. What about protein diet? High protein, low protein. He is in encephalopathy. Okay, this is again controversial. Okay, patient is cirrhosis is already negatively metabolic, so their proteins are low. So you give high protein, they will go into encephalopathy. You don't give, they will continue to be catabolic. Okay, so you should use a protein diet which should be from the vegetable origin. Animal protein should be avoided. Okay, preferably vegetable protein like dal or this something can be used, but not the egg and all those things. So they should be told about. Most of the time, alcoholic liver disease management is most of the other things. So stop alcohol, use the low salt diet, diuretics judiciously, and then nutrition. Protein should be given enough to this thing, and again, patient should be on syrup loose. All hepatotoxic should be stopped, and they are deficient for B complex timing. All those things should be given. Okay. Any other doubts in this thing? Thank you. So this case is a chronic liver disease, but history and all is not fitting. But many times you may be confused with what patient remembers and. Yeah.
2:30 will assemble, reassemble. 2:30. All of you go have to drink. Patient attendance.
Cardiac case or respiratory case? Cardiac is better to first. respiratory cases. Yes. So maybe 45 minutes.
ಹ್ಮ್
80. Maybe. Vivek. Vallabhaneni, Suride, Chinnati Suride, Surendram. Last body and waving.
Good afternoon. We are presenting these series. We have 55-year-old male from Gaussian Nagar, Mudagiri, Mysore, studied up to 10th standard. He used to work in the printing press, currently is unemployed. Stopped working about 4 years ago. Informed the self and date of examination is 21st of this month. Patient has found chief complaints of chest pain, palpitations, easy fatigability since 7 years, breathlessness since 5 years, and swelling of both lower limbs since 4 years.
Since 7 years, clarification since 7 years.
HOPI, the patient is apparently his usual state of health till 7 years ago. He developed chest pain, initially in the left side of chest, which was sudden onset, crushing type. It was radiated with the left arm, lasting for around 5 to 10 minutes, aggravated on exertion, relieved on rest. It is associated with diaphoresis, initially undergoing routine work, that is NYHC class 2, and progressed over a period of 6 months to see the patient chest pain even for less than ordinary physical activity like brushing teeth or dressing, that is NYHC class 3.
3 or 4?
3, sir. It was not at rest, only when doing like less than ordinary activity.
Rest he was.
At rest he was alright.
Okay. This is angina.
angina.
So you must be knowing that angina is classified based on blood. NYHA is for bloodlessness. Angina is for Canadian Heart Association. Okay, so it's almost same, but the angina is made from Canadian Heart Association. Breathlessness is from the New York.
A patient also gives history of palpitations, which was slow onset and offset, regular, which the patient described as a pounding sensation in his chest, more on exertion, lasting around 5 to 10 minutes and relieves on rest. Not associated with syncope or post-palpitation diuresis. Initially used to have it on routine daily activities, that is NYHA class 2, progressed to palpitations while again rest and ordinary physical activity is NYHA class 3. And patient also complains of easy fatigability since 7 years. In serious in onset, initially doing routine work, gradually progressed over 2 to 3 years, where he was rest.
What is this easy fatigability different from the breathlessness, or both are same? What does the easy fatigability indicate? Breathlessness indicate?
Breathlessness is more like left heart failure.
Yeah, heart failure. Easy fatigability can occur in a heart failure, but again, easy fatigability, there are multiple causes. Most common cause of easy fatigability is anemia. Okay, or it could be due to endocrine diseases like hypothyroidism, hyperthyroidism, Cushing's, Addison's, diabetes. So easy fatigability is a general symptom, can be seen in any condition. But patient with heart failure, liver disease, or even kidney disease, all of them can have a easy fatigability. Yes. And even a chronic infection, patient can have a easy fatigability.
A patient then went to Jayadeva Hospital for these complaints in 2019, where an ECG echo was done. He was told to have a heart problem. He was managed on OPD basis and prescribed.
Jayadeva in Bangalore or here?
Mysore.
Mysore Jayadeva. Okay, I have Dr. Dhruv Sadananda. He is still there, I think, actually.
He was managed on OPD basis, prescribed oral medications, after which his symptoms, after which he had some relief.
He was told to have a heart disease. Okay.
Yes.
Then
following that, since 5 years, patient gives history of breathlessness, which is insidious in onset, worsen on exertion, relieved on rest. Initially, it was NYHA class 2, then progressed over 6 months to NYHA class 3. So it was associated with history of episodes of PND at night. There was no history of orthopnea, no seasonal or diurnal variation of the breathlessness, and no associated
episodes of PND present, but never had orthopnea. It's just one question. What does the PND indicate? What does the orthopnea indicate?
PND is specific for like LV system.
What is PND?
Paroxysmal nocturnal dizziness.
Typically, PND is that patient will be comfortable on lying down at rest, but after 2 to 3 hours, gets up with the breathlessness, will have a something like a air hunger, goes to the window, takes the breath, because a patient may have a large amount of sputum in the sense pink frothy sputum. That's a typical attacks of PND. Whereas orthopnea patient never lies down. Okay, which is more specific symptom of heart failure. Actually, it's a PND, because this is just what I am telling you is that yesterday I think Dr. Brownwald expired. He's considered father of water, one of our physician colleague. Not now. I think in many years when he was doing the discussion with the PGs, he was a postgraduate. PND is more specific or orthopnea is more? Which occurs first, PND or orthopnea? PND has to occur early, orthopnea is a later. So that time he wrote a letter, not an email, to the Dr. Brownwald. Okay, so do you expect a Brownwald being a father of modern cardiology respect? So he has written a reply back in 1991 or something, saying that PND is more specific of heart failure, and that he had put it in he has published it in the journal, not before his death only. He is such a great personality. Somebody has written a letter from India in a England letter or something. He didn't thought that it was urgent, and about 1 month later, he got a reply saying that PND is more specific of heart failure. So that's not the importance of great people. That's why the Brownwald is considered as a great, because somebody has written a letter asking whether PND is important or orthopnea is important. So yesterday Brownwald, he had put it. So this letter is from Dr. Brownwald, not now. About 3 months, 4 months back, he had put it in our group, like that Brownwald replied to My email no. Letter by post that time from the America. Okay. Yes. So PND is more specific, but PND like episodes can occur in any patient with respiratory patient can have PND like episode. It can be the respiratory patient with asthma. He lies down, he gets a wheezes, he gets a better, or patient with COPD can get better. But PND typical attacks are strongly suggestive of left heart failure, pulmonary edema. Okay, orthopnea like episode, orthopnea, any patient usually heart failure, they will not be able to lie down, they need 2-3 pillows to lie down. But during the COPD acute exacerbation also, patient may have to sit. But when the patient typical history PND and orthopnea, you suggest that it is a heart failure. So he had never PND orthopnea according to you. Not yet developed. Okay. PND. ಮಲ್ಕೊಳಕ್ಕಾಗತ್ತಾ? ಸೀದಾ ಮಲ್ಕೊಳಕ್ಕಾಗತ್ತೆ, ಈಗಲೂ ಆಗತ್ತೆ. ದಮ್ಮ ಬರ್ತದೆ ರಾತ್ರಿ.
There is history of bilateral lower limb swelling since around 4 years. In serious onset, initially on the level of the ankles, it gradually progressed to the mid-thigh over about a month. It is more in the evening associated with swelling around the face and abdominal distension. There was no associated pain or tenderness with the lower limbs.
So he had a pedal edema, then ಹೊಟ್ಟೆ ಬಾತ್ಕೊಂಡಿತ್ತ? ಹೊಟ್ಟೆ ಬಾತಿತ್ತ?
There is no history of syncope, no history of cough, expectation, hemoptysis, no history of yellowish discretion of the eyes, no history of melena or hematemesis, no history of reduced urine output of frothy urine, and no history of fever.
Okay, what is the cardiac cause of hemoptysis?
Mitral stenosis.
How does it cause hemoptysis?
Pulmonary hypertension and pulmonary congestion.
Okay, if patient has got hemoptysis now, after 2, 3, 6 months later, hemoptysis comes down. What does it indicate? The question is it an early sign of mitral stenosis or a late sign of mitral stenosis? It's an early sign of, it's due to venous hypertension, capillary rupture. So it occurs early in the mitral stenosis, patient has got a venous hypertension. But later what happens? Patient develops arterial hypertension. Pulmonary arterial hypertension occurs, you will not get a hemoptysis. But the causes of hemoptysis in mitral stenosis, there are multiple. So when the patient, what is the mechanism of arterial hypertension, pulmonary arterial hypertension in mitral stenosis? It's a back pressure. Okay, one. Second, reflex vasoconstriction. Whenever there is a atrial fibrillation of the reflex vasoconstriction, third, hypoxia is part of that. Then the last one is a mechanical vascular changes occur in the, there is irreversible state. Vascular hypertension occurs in the vessels. Okay, so these are the 3 mechanisms of hypertension, pulmonary arterial hypertension, and mitral stenosis. Again, hemoptysis in mitral stenosis, there are so many causes. What are the causes? First is venous hypertension. Secondary, there is something called winter bronchitis. So patients are prone for recurrent bronchitis. Sometimes it may be considered as a bronchitis. Third thing is a pulmonary edema. That's a big frothy sputum. Then fourth one is a pulmonary infarction occurring in a pulmonary embolism. Then last one is a pneumonia, or these things are also more common in mitral stenosis patients. So there are 4 or 5 mechanisms patient can get a hemoptysis. Otherwise, cardiac disease causing hemoptysis is not common. So he didn't have any time hemoptysis. Okay.
Patient is a known case of hypertension since 8 years on treatment. Not a known case of diabetes, thyroid disease, seizure disorder. There is no history of TB in the past. Treatment history, patient is currently on these medications. Dapagliflozin, bisoprolol combination in the morning, torsemide spironolactone combination in the afternoon, sacubitril valsartan in the morning and night, aspirin atorvastatin combination in the night, and telmisartan in the morning.
Okay. Anything else in the past? No.
At the age of 14 years, patient does give a history of episode of fever, sore throat, multiple joint pains, both knees and small joints of the hand, for which was given a Benadryl injection for 5 days.
He remembers that?
He remembers that.
Okay. So, usually, most of the patients, when you detect rheumatic heart disease in the later age, you may not be able to detect this thing. So, how do you diagnose? If this patient had a BD injection, that's what we commonly ask, white injection monthly. Before that, admission with the joint pain and the breathlessness. Otherwise, sore throat, nobody will remember how many sore throats we have. So, If there is a history, it strongly suggests that he had a rheumatic heart disease, probably at the age of 14 years. So,
But he did not receive medicine injection for 21 days, 5 days and stuff, according to the patient.
after that he did take. Either is injection ಕೊಟ್ಟಿದ್ದ ಮತ್ತೆ ತಿಂಗಳಿಗೆ ಒಂದು injection ಬೇಡ ಅಂದ್ರೆ. So okay. So what is this peridure? What is peridure? It's a benzathine penicillin. It's a long acting. It has to be given deep intramuscular once in 3 to 4 weeks. And it's a rheumatic fever prophylaxis. When you give it, how long you give it? No, indications. First is a patient has got a rheumatic fever without carditis. So rheumatic fever can occur without carditis. So rheumatic fever is it can, what are the 5 components? You know that pancreatitis, polyarthritis, chorea. Okay. Out of that, ASO titer being positive, major criteria, minor criteria. Because we don't see now rheumatic fever, very less common, as India has become like a developed country. So when we were at PGs, we used to see frequently. So when you got a patient has a rheumatic fever, patient has polyarthritis, bleeding, joint pain, and some evidence of rheumatic ASO titer being positive, surface is positive, you make a diagnosis of rheumatic fever. You give it for a minimum period of 5 years. Patient has got rheumatic fever with carditis. Longer period is required because once the carditis is there is a progressive damage. But the patient has got a rheumatic heart disease. What is rheumatic? Most commonly valve involvement. The most common is the mitral stenosis. It should be given how long? The 10 years is for rheumatic fever and carditis. Preferably lifelong, but nowadays they say up to 35 years because the incidence of rheumatic fever after the 35 years is very less. There are extremely rare cases of rheumatic fever being noted at 60 and all. It's extremely uncommon after 35, 45 years. So many of the time they stop it. In this patient, he didn't receive the prophylaxis. Okay, yes.
Surgical history, there's a history of right inguinal hernia surgery about a month ago. There's a history of hemorrhectomy in 2011. Patient has recurrent hospital admissions over the past 4 years with similar complaints. 7 times has been admitted.
All times he was admitted with same symptoms.
Yes, sir. Okay. Family history is a 4th born out of 3rd degree consanguineous marriage. He has 2 elder sisters, both passed away at the age of 60 and 55 respectively due to heart disease, query MI.
What is that patient? 2 people, like male and female, what is it? Elder sisters. What is premature coronary artery disease and family history of coronary artery disease significant? When you say first degree relative, yes. Any male member below 65 years, females below 55 years, but actually incidence of coronary artery disease is 1 decade earlier in India. But still to say premature, the standard definition below 65 for a male, unexplained sudden cardiac death, which is assumed to be coronary artery disease. Females below 55. So, no, opposite. Males below 55, females below 65. Because females have got menopause and this. Okay. And 2 family members died due to heart disease at the age of 60 and 55. So he has got a predisposition, you can take. Okay, yes. And both are females, both died before the 65. Yes.
1 elder sister and another younger sister, both are alive and healthy, sir. He has 1 son, 11 years. Personal history, consuming mixed diet about 1,900 kilocalories per day.
How did you calculate 1,900 kilocalories per day? It's very difficult to calculate for our day-to-day calories. Okay, yes.
Appetite is good, sleep is undisturbed. Bowel and bladder habits is regular, but there's increased frequency of nutrition since you started on heart medication. Habits non-smoker, non-alcoholics.
Okay.
Summary.
Yeah.
We have a 55 middle-aged male patient who's known hypertensive since 8 years on regular medication. Has common complaints of angina, external palpitations, and easy fatiguability since 7 years. Breathlessness since 5 years and bilateral low limb swelling since 4 years.
So, see, you consider 3 symptoms. He has got angina, he has got palpitation, he has got a pedal edema, and easy fatiguability. So, what are the 3 symptoms? First, you take the angina. According to you, he's got a typical angina? What is typical angina?
Retrosternal crushing type can radiate either to the jaw, or the left shoulder, or to the back. So we are engaging in diaphoresis. Usually worsens on exertion, reduce on rest.
Okay, typical angina lasts for
Less than
2 to 5 minutes. It doesn't last longer. Okay, what is unstable angina? It's a stable angina. Okay, what is unstable angina?
last more than 20 minutes.
It lasts for more than 10 minutes of this thing. Previous angina which has become crescendo, it means more in severity, more in frequency. Say earlier I used to climb one stair. Now even one stair I get a pain. That is a crescendo angina. Or any angina, new onset is considered unstable angina. Post myocardial infarction, pain should subside. If the patient has got a pain, it's also unstable angina. Any patient is at rest, develops angina. So if it is a typical. Okay, let us hear to there is an angina equivalent. What are the angina equivalents?
Diaphoresis, breathlessness.
Usually exertional breathlessness, exertional diaphoresis, yes. Then next, more commonly, exertional syncope. A most important symptom which is a dyspeptic symptoms. In the elderly, first time you start developing dyspepsia, strongly suspect angina. Like the first time. So after food, related to food, whatever it is there, it is to be strongly suspected angina. Even exertional syncope can. Most of the time confusion is a dyspepsia, acid, gas. So that's the most important. So patient has got angina. When the patient has got angina, what was his age when he had developed angina? He is 55 years. He is a known hypertensive. So his hypertension occurred first or angina occurred?
Hypertension.
Okay, hypertensive patient can have angina. Or any patient who is 55 years has developed typical angina. What is the interpretation?
It could be hypertensive heart disease.
This could be hypertensive heart disease. What does it happen?
Concentric LVH happens.
Like concentric left ventricular hypertrophy. What happens that there is a increased demand. Coronary artery disease is decreased supply. When 50% of the coronary arteries are narrow, when you exert, you will get a pain. Okay. Whereas hypertensive left ventricular hypertrophy, the demand becomes more, patient can have angina. Or second mechanism,
Decrease supply.
hypertensive patient is prone for atherosclerosis. He could have developed atherosclerosis. First thing is the most common disease is coronary artery disease is first possibility. Then he developed angina. What are the other causes of angina? Non-coronary causes. One is hypertension. Yes, then
Pericarditis.
angina. Pericarditis is not angina, it's a non-angina chest pain. Okay. So next most important cause of angina is aortic stenosis. What is the mechanism of pain? Again, it's the same. Concentric left ventricular hypertrophy, and the patient demand is more, supply is same. But again, aortic stenosis. Nowadays, earlier days, it was mitral stenosis was the most common cause of coronary heart disease. Now, all over the world, aortic stenosis has become the most common disease. So, patient has got a aortic stenosis. They may have an angina as one of the first symptom. So again, angina in aortic stenosis has got a prognostic importance. So, patient has got angina, survival is for 3 to 5 years. Next cause of angina is what there's this thing, excessive demand. Again, angina patient, aortic stenosis patient, because of the age, they may have associated atherosclerosis. Next cause of angina. Yeah, we'll come to that. Valvular heart disease like a aortic regurgitation. How does it cause angina?
Normally there are nocturnal angina.
It's also called nocturnal angina. Typically seen in earlier days, syphilitic heart disease. So usually, what is the mechanism of angina there?
Night parasympathetic stimulation, more heart rate decreases. Less heart rate, more diastolic pain, more air, less blood flow to coronaries. So,
okay. First thing is that again, aortic regurgitation over a period of time, chronic AR, heart dilates and the demand is more. Second thing is that patient can have, what is it called? Coronaries fail during diastole. So when the diastolic regurgitation is occurring, coronaries will get impaired. So left ventricular hypertrophy demand is more. That can lead to, and last what he told is that is called syphilitic angina, aortic regurgitation. Okay. Can mitral stenosis patient have angina? Can the mitral regurgitation patient have angina?
pulmonary hypertension,
Mitral stenosis patient, right ventricular hypertrophy, right ventricular ischemia may cause exertional chest pain, looking like angina, but it's not a typical. Okay. And again, mitral stenosis patient are more prone for atrial fibrillation. Some small emboli can form to coronary. Possible. Mitral regurgitation. Mitral regurgitation and angina. It's opposite. Mitral regurgitation occurs due to coronary artery disease, papillary muscle dysfunction, ischemia to the heart, papillary muscle. Patient has papillary muscle dysfunction, has got a mitral regurgitation. Primary cause of mitral regurgitation is ischemic heart disease. Okay. Next is mitral valve prolapse. Mitral valve prolapse is another common disease. They can have a typical chest pain, but it's atypical chest pain. It's not a typical angina. More common in a females. Okay, so again they can have chest pain. Okay, any other cause of chest pain other than as she told pericarditis? Then question comes. Pulmonary embolism. Okay, anything else? Aortic dissection. Aortic dissection, severe pain. Again, radiating to the back, a patient will be in shock. So it will not be one type phenomena. So this patient had angina. So possibility first still could be either hypertensive heart disease or coronary artery disease. Okay. Then next symptom you had a exertional palpitation. What is the palpitation? How do you assess the palpitations?
Volume overload.
What a defined palpitation you would assess?
Palpitations is abnormal and your awareness of one's own heartbeat, you will change the rate or rhythm of force of contraction.
So there are only two mechanisms of palpitation. Either there should be change in the rhythm, okay, or change in the cardiac output. So abnormal, uncomfortable. Most common cause of palpitation is arrhythmia. So palpitation, you have to take history. How did it start? How did it progress? Is it regular or irregular? What precipitated? What relieved? Is there any sudden onset of post palpitation diuresis? These things you have to ask. In this patient, he had exertional palpitation.
It was relieved on rest. The onset was slow, sir. There was no post palpitation diuresis, no associated syncope, and it is regular.
Was it regular? So you have to ask the patient, is it like this or like this? So if the patient is young, so he says like this. It's a pounding of heart. Pounding of heart. So anybody who has got an increased cardiac output, the most common diseases which present as a palpitation is a mitral regurgitation, aortic regurgitation, and volume overload state like VSD, PDA, and non-cardiac causes are more common. Anemia in the cardiac output, pyrotoxicosis, very AV fistula. And again, drugs can cause palpitation. What are the drugs? We commonly use. You give a nebulization, salbutamol, beta-2 agonist. Okay, so most common cause of palpitation is there. And excessive drinking of coffee. All these things can cause palpitations. So, when the patient has palpitation, most important thing is it related to regular or irregular. So, most common is the arrhythmia, which you have to think as a arrhythmia. Even tachyarrhythmia, bradyarrhythmias also can be felt as a palpitation. Like bradyarrhythmias are distinct, normal beats. It can be ectopic beats. Ectopic beats is what patient feels that some beats are missed. So, my heart stop for a minute, like that. So, severe bradycardia also patient can feel. If the complete heart block is there, increased cardiac output, patient can feel palpitation. So, you have to find out what is the cause of this palpitation. So, is it a due to volume overload or is it arrhythmia? Again, arrhythmias, most common arrhythmia in the ward or in the hospital or non-hospital patient is a atrial fibrillation. So it will be irregular. Patient may or may not notice. If the patient is able to notice, it will be irregular, present throughout the day and night, more prominent during exertion. So that is a typical. The patient will have palpitation, sometimes he may not be aware, sometimes. Whereas increased cardiac output, patient may become more during exertional activities. So when the heart rate is gone. Okay. Fourth symptom is easy fatigability. It could be due to heart failure or it could be due to any anemia or any other condition. So fourth symptom is a breathlessness. That's another cardinal symptom of heart failure, which I told already. PND is very specific of left heart failure, and he had episodes of PND for 5 years. This symptom of breathlessness in all valvular disease. Mitral stenosis, what is the most common presentation? Exertional dyspnea. Okay, and the hemoptysis can be there, and next palpitation can be there, and many times you may find for mitral stenosis patient first time admitted with stroke when you detect embolic stroke. And earlier days we used to see what we treat as bronchitis, it will be due to mitral stenosis. Okay, so next is mitral regurgitation. What is the symptom?
Palpitations.
Palpitation is an important symptom of mitral regurgitation because it's a left atrial volume is coming, left ventricular volume coming, it's being pumped, patient will have it. And again, later what happens? Pulmonary hypertension develops. Pulmonary hypertension develops. If it's acute mitral regurgitation, patient can go for heart failure, they can have a severe pulmonary. If it is a chronic MR, what happens is that mitral stenosis, left atrial pressure rises. Mitral regurgitation also left atrial pressure rises. Mitral stenosis, mitral regurgitation, which will be tolerated better? MR will be done. Left atrium is receiving the weight, it will start dilating, it will slowly enlarge. So where do you get the GI left atrium? It's a mitral regurgitation, not a mitral stenosis. Mitral stenosis, left atrium is enlarged, but in pressure hypertrophy is there. Mitral regurgitation will cause slowly progressive left atrial enlargement, and it will be transmitted back when it starts to right ventricular pressure rises, patient will have a feedback. So that is a symptom. Whereas in aortic stenosis, as I told, among all the valvular disease, it is the most important. It can cause classically, first symptom could be angina, second symptom is a syncope. So why does the syncope occur in aortic stenosis? Again, three mechanism is there. It's aortic stenosis is a condition where there is a fixed cardiac output. So artery valves are narrow. Heart cannot, when you exert, cardiac output has to increase. So when you exert, it's a typically aortic stenosis will cause what is called exertional syncope at the height of exertion. So patient, when you exert, normally what happens? Vasodilatation occurs very quick. Muscle bar, this thing. Heart will increase the cardiac output. But in aortic stenosis, it cannot happen. Second thing is when you exert, what happens? Systolic blood pressure may come down because of vessel. So hypotension occurs. Third thing is a ventricular arrhythmia can occur. So that is the mechanism which can cause sudden cardiac death in aortic stenosis. So syncope, angina, breathlessness. And the aortic stenosis patient again, one episode of heart failure. And the aortic stenosis initially left ventricle is a big chamber. It will go on tolerating one hypertension when left ventricle fails. That is a manifestation of PND or arrhythmia. So initially they can have exertion, then they can have heart failure. So patient has got breathlessness prognostically 6 months to 1 year. So aortic stenosis, breath symptoms are directly related to this. But whereas aortic stenosis, aortic regurgitation mechanism is different. So most important here he has got a no syncope. No syncope. Okay. So bilateral lower limb swelling means he has got a right heart failure, pulmonary hypertension. So which occurs for pulmonary hypertension occurs earlier in aortic disease or pulmonary mitral disease? It has to be mitral disease. Okay. Mitral stenosis will cause pulmonary artery. Aortic stenosis it will take much more time. So he had a congestive heart failure, but he has got, in addition, he has got a hypertension. Could be he could have also had a coronary artery disease. Okay. Ischemic heart disease you have written, that's the most common. Hypertensive heart disease, valvular heart disease, aortic, likely you have written, right?
Because symptoms have been going on for more than 5 years, and pulmonary hypertension actually developed after the 5 years.
So his symptom occurred first is exertional breath dyspnea. Palpitation is a symptom. It could be mitral disease, it could be aortic stenosis, aortic valve disease. Okay, regurgitation more likely than stenosis, right?
Still palpitation is there.
Yeah. Severe anemia in heart failure. Severe anemia in a male at 55 years. What could be the cause? Yeah. But again, very unlikely they survive for another 6-7 years on treatment. Okay. So anemia could be in a male, it could be malignancy, it could be eclamptic anemia, or it could be nutritional, it could be B12 deficiency, so many causes could be there. Again, severe anemia and failure which you patient with a fetal edema by sugar and palpitation could be additional stress. Okay. And again, anemia patient can have a excessive angina. So because oxygen carrying capacity is reduced.
General physical examination. We have a middle-aged male, moderately built, moderately nourished, conscious and cooperative, well-oriented, time-facing person. Height is 157 centimeters, weight is 49 kg, BMI is 19.9. Arm span is 162 centimeters. So arm span.
How did you tell measurement? Why did you take? Okay.
And the arm.
Okay. Why did you do this? Is he having a morphoid features? Is he having a morphoid features?
Height doesn't fit, sir.
And even the height and his body habitus doesn't fit. So you have got a patient is tall, arachnodactyly, high arch panel. Okay, in that condition, sometimes when you check it, okay, which sign is it? In this patient, he will no way he looks like a tall morphoid habitus. Okay, what is morphoid body habitus and what is morphoid syndrome? Both are same. Marfan syndrome, they will have a Marfanite body habitus is only tall fellow with the skeletal abnormalities. When you have got a aortic wall disease and a lens this thing, and then patient has got this, there is a criteria, this called some basic criteria or something to say Marfanite. Okay. Otherwise, it's a body habitus. He doesn't look like a Marfanite. Okay. Anyway, he doesn't look like that. Okay. Next.
There is no parallel picture sign of this having a lymphadenopathy. Malaria can be very much
Very mild. Very develops. Bilateral pitting edema is present. So he doesn't have much heart failure symptom now, but he has got edema. What could be there? Is that diabetes? Okay. Still has got edema. Is he on calcium channel blocker or glitazone or testosterone? Renal. Okay, it doesn't appear to be. I don't think it's much edema.
Vitals, pulse is 86 beats per minute, regular rhythm, high volume, collapsing pulse. Pulse is dyspnea.
Collapsing pulse. How do you do actually? What do you do? What you should do? You should feel the pulse here. Then proximally use the other hand. Not feeling when there is a more muscular artery then you should take it. And if you have got a classical pulse, only thing is that because it's high volume, I'm not very certain it's quite high volume. Volume is okay, but blood pressure is what we will decide to stick. So systolic blood pressure 152, if you are right, your volume should be good. Otherwise, patient can, aortic stenosis patient also can have low volume pulse or normal volume pulse. They are associated with aortic stenosis or mitral stenosis or it is in heart failure. So he is walking around very unlikely to be in heart failure. And the first volume it's not very high volume. The collapsing depends all peripheral forces are
ಇದು ಆಫ್ ಮಾಡೋದು ಹಿಂಗೆ ಇದು ಬೇಡ.
Secondly, to aortic root dilatation, very syphilitic aortitis with severe pulmonary hypertension. Patient is not in AF. In heart failure, NOHA class 2 on treatment, no signs of infective endocarditis, rheumatic activity, and systemic hypertension.
Okay, so your diagnosis is a severe aortic regurgitation due to syphilis. History of exposure of this
No
thing?
history of exposure.
Okay, because it's a purely
aortic regurgitation.
aortic wall disease. But if you say syphilis, at least you have to get the history of exposure. That I think you did tell in the history. Okay, again, it's a severe aortic regurgitation. What made you think it's severe?
Peripheral signs, sir. Hill sign is more than 60.
Hill sign is more than 60.
And other peripheral signs.
Other peripheral signs of gross leak are not there. Okay, diastolic murmur is long, that means that. How do you make the severity of aortic regurgitation? One is Hill sign, definitely. Long the diastolic murmur.
The duration of the diastolic murmur.
Duration of diastolic murmur, then?
It's not almost all throughout diastole,
Yeah.
so it is severe. So associated pulmonary hypertension.
Associated pulmonary hypertension. In a patient with aortic regurgitation, again pulmonary hypertension is late. If it is there, what you should think always? Associated mitral valve disease, mitral stenosis, or some amount of mitral regurgitation. Okay, so here there is a murmur according to your mitral area, but is it a mitral stenosis? Loud first sound is not there, opening snap is not there, and it is not very low pitch. It's little high pitched only. Okay. So severe pulmonary hypertension, is there any tricuspid regurgitation associated? You can't cut. Okay, you're not getting. Only TR murmur. When severe pulmonary hypertension is there, you expect a functional or TR. Okay. Yet clinically not in atrial field. Instead of that, you can write it in sinus rhythm. In heart failure, NYHA class 2. Why do you say NYHA? He has got heart disease. Is symptomatic?
Not symptomatic.
Okay, it's class 1 or class 2. Infective endocarditis, rheumatic activity, systemic hypertension. So he has got a blood pressure of 150. Is it systemic hypertension or is it due to aortic regurgitation? Aortic regurgitation. Because he was told to have hypertension before the knowing this thing. Okay. Yes. So systemic hypertension was told before only, no?
8 years.
Huh?
Systemic hypertension since 8 years. Other symptoms started since 7 years.
7 years. Okay. Yes. Okay. So only two things, that is there any associated mitral stenosis or is there any coronary artery disease? So what test you want to do?
CBC, RFT.
One more thing is there. Is it acute AR or chronic AR?
Chronic AR.
It's all signs of chronic AR. Acute AR rarely occurs with aortic dissection or blunt this thing. What is diastolic MR? Have you heard a term called diastolic MR? In a severe acute AR, you can get a MR. Mitral regurgitation can occur in a diastole also because the blood is regurgitating. It can occur. Not commonly. Severe AR, heart cell, it will not get a peripheral sense. Okay. So in this patient, he has got a chronic severe aortic regurgitation. That is definite. Is there an associated aortic stenosis? Because BP is according to 150. When you suspect of aortic stenosis? Systolic decapitation. When you get a gross aortic regurgitation, systolic blood pressure will be in the range of 150 to 200 and diastolic will come to 0. He has got diastolic of 50. That's why the peripheral is 150 or how much was that?
50, sir.
Okay, 50. So you are not able to hear till the end. Okay. So are associated mitral stenosis are this thing. So here, and you told that he had taken a treatment for joint pain and this thing. That makes strongly suggestion of rheumatic heart disease than syphilitic. Okay. Why do you think it's syphilitic? Yeah. Can the isolated AR occur in a rheumatic heart disease? No.
Usually in isolation, AS or MR.
Not there. Usually, mitral valve involvement is 60%. Along with the mitral with aortic valve is around 30%, 60 to 90. Along with tricuspid, it becomes 95. Pulmonary valve involvement is not known, but less than 5% of cases can be pure aortic regurgitation. Very rare. Okay. So, and when you get a pure AR, most important is it rheumatic or syphilitic? How do you distinguish?
S2, sir. Usually syphilitic S2
First is age wise. Rheumatic AR occur in a younger age. Syphilis, it's a tertiary syphilis, older age. Okay, second. Pure AR with the gross signs in a syphilis. Usually mitral valve syphilis. Okay, next.
Syphilis is mostly there is this root involvement, sir.
Aortic root involvement, then
rheumatic is
the murmur of a syphilitic AR is heard where aortic distinction is.
neo-aortic area, sir.
Neo-aortic area is in
Left side.
syphilis. Yeah. Valvular due to rheumatic.
It is west side in the aortic area.
Aortic area. Okay, then
loud S2, sir. Normally
loud tambo cavity in a syphilis. Then
they might have history of yes,
exposure. Okay, then
lesions.
Then
Other stigmata of syphilis.
other stigmata, what are the things?
Saber shins or Hutchinson's triad notched out.
Okay.
Shins in your hearing loss.
Okay.
This will get it.
Okay. But can you confirm by here? Is he having a syphilis or syphilitic or this thing? So what test you want? You have got ECG, X-ray, echo?
This is the CBC, sir.
Okay, anything abnormal?
No, sir.
Okay, next.
This is the RFT. Creatinine 1.22. This is on a normal 25, sir. No follow-up.
1.907. 1.22. Okay.
Previously it was 1.05. 3 months before that. Electrolytes potassium was 5.09, otherwise normal. LFT total will be 2.21. Direct was 1.07. Enzymes normal, sir. And
what is the ECG show?
So sinus rhythm. There is LVH by voltage criteria with no strain pattern.
Can you see that voltage criteria? Can you say it is a volume overload or is it a pressure overload? Where you get a volume overload? Regurgitation. Where you get pressure overload?
AS or
so can you look at the ECG and tell?
Like you'll have a strain pattern in T inversions.
So in a volume overload, V5, V6 will be very tall. There will be prominent small Q wave and T wave will be upright. Whereas in pressure overload, you will get a STT changes. So here there is not much STT changes, but volume, this thing is very high. Okay, so on the axis is left axis.
Left axis and LAFP is there, sir.
Left anterior heavy block is there. So it could be due to hypertension.
Hypertension.
Okay. Lateral STT may be due to hypertrophy. Okay, abnormal is the next. Echocardiogram. What does this heart shows?
Cardiomegaly, sir.
Is there any sign of mitral stenosis here?
Left, like left. There's no.
It's not there.
Heart borders.
Okay, you can see if it is all left atrial enlargement. What has happened to the aorta in the right side? Aortic ascending this thing.
Prominence.
Prominence is there. Okay, then.
Probably root.
Is there any calcification or anything? Okay, next.
This is the report, sir. This echo was done in Jayadeva in 2025, December. But it shows dilated cardiomyopathy, LV global hypokinesia, dilated aortic root, moderate MR, moderate AR, severe TR, severe pulmonary hypertension, concentric LVH, EF of 44%. No obvious clot.
Okay, there's a moderate mitral regurgitation. Is there a mitral valve? What they have commented? Is it thickened?
Mitral valve is normal.
Okay, so what it could be?
Flow mark.
Which one?
The MR is no.
MR is due to LV dilatation, functional distress. So severe MR, severe TR. There is a severe pulmonary hypertension. What does it mean? Pulmonary long-standing AR can be there, or there is associated severe mitral regurgitation. But the valve they have not commented. So if you got a severe MR, severe TR, no pulmonary hypertension, it makes suggestion that it's a dilated cardiomyopathy. When the pulmonary hypertension is there, there's an organic pathology. Either AR must have been severe, present there, and moderate MR, is it what is the cause? Is it due to rheumatic activity? Okay, next. So what is the final thing the cardiologists are feeling? It's not a, is it a syphilis? Any other test you do?
VDRL is negative, sir. actually.
VDRL is negative. Next.
TPHA report you cannot find, sir.
TPHA report is not there. Okay. So it's very difficult to believe it's a pure syphilis. I think he must have the. Is it echo was not repeated?
No, sir, not after that. There was an echo done here, sir.
Is it you have the? It will report in the animal. Heart in the echo test. Other Sharma idea. Okay. Because it's very difficult to believe two things: moderate MR, severe pulmonary hypertension. Again, the murmur is not very prominent. Pulmonary hypertension signs are there. It is loud. Okay. No obvious clot. And what is the any procedures they have done?
No procedures done, sir.
Only he is on heart failure medication.
Heart failure medication.
So what is the ejection fraction?
44%, sir.
So what is the rule of 55 in the 50 and 55 in the mitral regurgitation?
Severe AR with if ES is less than 55%, he's a candidate for aortic regurgitation. Or if the LV end systolic diameter is more than 50 millimeters.
Yeah, this is called rule of 55. Even if the patient is asymptomatic, particularly in mitral, normally when you get a 55 ejection fraction, it indicates that patient has got a good this thing. Whereas in a mitral regurgitation, when the ejection fraction falls to 60, it's already failing heart. Grade 3 MR, eccentric, moderate TR. Again, I didn't ask it clearly. So it's a mildly different. It's not syphilis. It's a multivalvular heart disease, severe AR, mildly depressed LV function, severe pulmonary hypertension. That means that there is a mitral valve involvement. Again, there is one more. This is aortic aneurysm, severe AR, severe MR, global hypotension, depressed LV function, severe pain, dilated cardiomyopathy. So only thing is that is it a dilated cardiomyopathy? When you say dilated cardiomyopathy, thanks. June ಇದೆಯಾ? ಯಾವಾಗ ಮೊನ್ನೆ ಲಾಸ್ಟ್ ಜಯದೇವ ಡಾಕ್ಟರ್ ನೋಡಿದ್ದೀಯಾ? Thanks. Okay. So,
sir, if there is moderate MR, won't you get a pansystolic murmur in the mitral?
I'm not able to clearly hear. What happens? Which will decide the severity? Proximal lesions or distal lesions? If he has got a moderate MR and severe AR, what will happen? MR signs should increase. Proximal, this thing should be more prominent. Okay. So, if there is a MR, here the mostly AR is very severe. MR signs should be increased if there is a valve involvement, proximal lesion. And he has got so much gross AR, there is definite. But only thing AR again is peripheral signs are not always, distal shot is not there. So something has come down. Is there association, but echo is not there. So we should have got a MR signs to be more prominent. Pulmonary hypertension is there. Definitely it suggests that there is a mitral valve involvement. Pulmonary hypertension is severe. So this murmur is a question, this thing. Okay, you have to see why he doesn't have a severe murmur. And this murmur again in the radiating to axilla could be systolic murmur, which is probably it's like heart like this naturally. It's very unlikely to be cholecystolic murmur. It's not that this thing. It's again gross signs of PR is not. So what you want to do for it? Does he need valve replacement? They have not commented anything so far.
EF is less than 44, so the severe AR is there.
Yeah, and again severe MR is there. So what if at all operation ಮಾಡಬೇಕಂತ ಹೇಳಿದಾರಾ? ಹೇಳಿದ್ರು. So I thought we. So their impression, have they done angiogram?
No, sir, angiogram is not.
Okay. So if they feel that it is due to cardiomyopathy, they might not be considering valve surgery. Usually cardiomyopathy will cause what? Classically, severe heart failure and MR murmur, TR murmur. Patient will have a heart failure. His heart failure is very well controlled. Is it a completely everything is hypertensive heart disease, which was not controlled? Can it be hypertensive heart disease? Can the hypertension cause aortic regurgitation findings? can occur, but it's not severe usually. Can it cause MR due to left ventricular chamber is enlarged? Can it cause pulmonary hypertension is associated with disease? So it's little abnormal to think that he has got rheumatic heart disease which is not requiring surgery. Coronary artery disease, there is not to say coronary artery because there is no regional wall motion abnormalities, and his ejection fraction is 44. He is doing, as far as I know, reasonably well. No pleural edema, no JVP, no third heart sound, no fourth heart sound. No. Yes. So no obvious clot. So it's little difficult to believe this clinical picture. So only this kind of things only cardiologist can tell. What is it? Is it so it doesn't fit into pure AR, doesn't fit into. So was there a mitral valve stenosis? Sometimes I think there is a previous cardiologist physician Raman had come to Manipur. So he is professor of medicine from JSSMC.
The class
the earliest DM program from Chitra. So then he came back to medicine. So he didn't like the cardiology. So he told that during one period, one shoulder or shoulder come with a severe chest pain or something. So aortic stenosis was there. They opened and operated. Then actually what they missed was a mitral stenosis. That is during the 1970s. Patient deteriorated after aortic valve. So he told that insurance. So sometimes with the availability of this thing, again, he may require catch studies, whether there is anything else. Because this is repeated echo done. I can't say no, it is done by cardiologist. But it doesn't explain his outcomes. Okay, thank you. I have also seen only I think there is associated by echo doesn't. ECG wise, it's a grass. When the mitral stenosis is there, again, aortic size will come down because mitral stenosis is prevented. Here it is not there. So mitral valve area they are not there. What is the normal mitral valve area? Not normal aortic valve area. Once becomes 1/3, it's severe aortic stenosis, but mitral area when becomes 0.5, it's critical stage. We'll go to the last case. Already 4 of it. Patient is here. Actually, respiratory medicine is considered as a graveyard of medicine because the signs are so difficult.
Mrs. C, 46-year-old female, hailing from Nanjangud, is a farmer by occupation, presented with complaints of cough since 7 days and complaints of fever since 4 days. Patient presented with complaints of cough, which was insidious in onset, persisting since her last hospital admission, which was 4 months ago. The cough is aggravated on exposure to dust and has increased in frequency over the past 1 week. She has bouts of cough, 3 to 4 episodes per day. It is non-expectorating, not associated with any dilutional, seasonal, or positional variation, and there is no limitation of daily activities. This was followed by complaints of fever and chills since 4 days, which was high grade, associated with myalgia, continuous, relieved temporarily on taking medication. There was no history of diurnal variation or night sweats present. No history of hemoptysis, no history of dyspnea or wheeze. There's no history of chest pain, no history of nasal discharge, epistaxis, throat pain or ear discharge, no history of weight loss, no history of decreased appetite, no history of belching or regurgitation of food, no history of hoarseness of voice, no history of palpitation, bilateral lower limb swelling or facial puffiness, no history of orthopnea or PND, no history of joint pain or rashes, no history of loose stools or vomiting. There's no history of any drug intake. She is not a known case of diabetes, hypertension, IST, bronchial asthma, COPD. Patient had history of fever and cough associated with weight loss and was diagnosed as pulmonary tuberculosis 30 years ago. She was admitted to TB sanatorium for 2 months, where she received injectable therapy along with oral anti-tubercular treatment. Sputum examination was performed, following which she was discharged and continued on oral medication for additional 4 months. Repeat sputum analysis was done and she was declared cured. She remained asymptomatic thereafter until 4 months ago, when she again developed complaints of fever with cough and was admitted to hospital. At that time, she was evaluated for tuberculosis but had tested negative. She does not have any history of COVID. She has received 2 doses of COVID vaccine in 2021. She has a normal appetite and is a vegetarian. Her sleep is undisturbed with regular bowel and bladder habits. There's no history of weight loss. She has she has history of biomass exposure, sir. She used to work.
She is exposed. She works in the.
So she's a farmer by occupation, so that makes a significant occupational history. And other than that, she used to use biomass at home, sir, for 25 years, for 3 to 4 hours per day. Other than that, no significant history. To summarize, a 46-year-old female with no known comorbidities and past history of pulmonary tuberculosis 30 years ago, treated and cured, presented with cough, increased in frequencies for past 1 week, not associated with expectoration, and complaints of fever since 4 days, with no history of hemoptysis, weight loss, night sweats, dyspnea, or chest pain. With this, I would like to consider my provisional diagnosis, first one being lower respiratory tract infection, second is cough variant asthma, third is post-tubercular sequelae with secondary infection, and fourth is reactivation of tuberculosis.
Okay. So why did you think lower respiratory tract infection is most likely because she had a short history of fever? Previously she was all good. Why did you think of cough variant asthma?
So because she typically gives history of cough and exposure to dust, sir.
Previously also.
Yes, sir. Since 4 months, she's telling it has increased. So previously, it was very occasional, but after in December, when she had got admitted, post that the frequency has increased.
What is her age?
She's 46 years.
46 years.
Yes.
Again, asthma starting at this age is little unusual. It is probably secondary exposure to dust or something. It's a chronic obstructive airway disease. Again, chronic obstructive airway disease, either there is 2 things. She has got a biomass exposure and she has got a history of tuberculosis. In India, at least pulmonary tuberculosis in the past, how many years back? 20 years back.
30 years back. Sir.
30 years back. So it predisposed to chronic obstructive airway disease. Did she give history of wheezing?
No, sir. Never, sir.
Never wheezing. Okay. If there is a history of wheezing, that strongly suggests a airway disease. Cough variant asthma patient may be more commonly seen in children, starts in the younger age. Patient will have wheeze. Wheeze is secondary. Okay. Post-tubercular sequelae with secondary infection. What do you mean by that?
So because of post-TB, there will be structural damage, which can lead to, because of the structural damage, most commonly being bronchiectasis, patient will have increased chances of secondary bacterial.
What is that called? Post-tubercular bronchiectasis.
Traction bronchiectasis.
For traction bronchiectasis can occur, but classically they may come with episodes of hemoptysis. It's called
bronchiectasis sicca.
Bronchiectasis sicca. जाएंगे भी उनके एक 15 निमिष तो बहुत class yes. So bronchiectasis sicca, they will have episodes of
hemoptysis.
But what about the sputum?
No sputum production.
Usually sputum will be less. Why?
Because it's
upper lobe. So usually bronchiectasis occurs in the lower lobe. Tubercular bronchiectasis because of the upper lobe, you will get a minimal drainage will be good. Okay. Reactivation of tuberculosis. Why did you think?
So, because in otherwise the criteria for presumptive TB is that it should be more than 2 weeks history. But in patients who have previous history of tuberculosis, less than 2 weeks can also be considered as a significant.
But again, reactivation, there should be some history of fever, weight loss, cough, cold. Nothing is there.
Only no fever is there.
She doesn't have hemoptysis.
No, nothing.
Okay. Yes.
Going to gender
Is she breathless? No breathlessness.
No breathlessness.
She is not in respiratory failure.
No. Okay. Patient is conscious, cooperative, and oriented. She is poorly built and nourished. Her BMI is 14. Pulse rate of 102, which is regular in rate, rhythm, volume, and character, with no radial delay or radiofemoral delay. Blood pressure is 110/80, recorded in right upper arm in supine position. She is maintaining saturation of 94% at room air. Her respiratory rate is 22 cycles per minute, which is regular, and thoraco-abdominal type. She was afebrile when she was examined. Her temperature was...
No other findings?
No, sir, nothing.
She is febrile?
She was febrile. Respiratory examination, upper respiratory tract, no significant findings, sir. no nasal flaring, no nasal cavity is normal, nasal septum central in position, no nasal polyps. Shape is asymmetrical. She has infraclavicular flattening on the left side, supraclavicular hollowing on the left side, intercostal retraction, which is seen bilaterally and just below the xiphisternum. There is no rib crowding. There's visible drooping of the left shoulder, prominent left scapular border.
Demonstrate the drooping, standing from the behind. Okay, yes.
And
so definitely there is a volume loss sign in
left side.
Left side. Okay.
Check is deviated to the left side. Tail sign is positive. Apical bead not visible. She has scoliosis present. Convexity to
scoliosis.
A convexity towards the right side, which disappears on bending forward. Respiratory movements. Intraclavicular area is reduced on left side. Mammary area is also reduced on left side. Supraclavicular area is also reduced. Suprasternal pulsations are seen. No visible sinuses. Hyperpigmented patch is present over left shoulder.
What is it?
So it's just a birthmark, sir. Coming to palpation, all the inspectory findings are confirmed. Trachea is deviated to the left side. Apex bead is felt in the left fifth intercostal space in mid-clavicular line.
This is not displayed.
No, sir. In the mid-clavicular line, sir. Supraclavicular, infraclavicular, and suprascapular movements are decreased on the left side. All the other movements are normal. Dimensions, her transverse AP ratio 7:5. Her chest circumference expansion is 2.5. Right hemithorax expansion is 1.5, whereas left hemithorax expansion is 1 centimeter. It is reduced. Spinocapular distance is reduced on the left side. Spinoacromium distance is increased on the left side. Vocal fremitus, supraclavicular, infraclavicular, axillary, and suprascapular vocal fremitus is increased on the left side.
Left supraclavicular is it left supraclavicular also? Okay.
Supraclavicular, infraclavicular, suprascapular, and axillary vocal fremitus is increased. There's no tactile fremitus, friction fremitus, no rib crowding, and scoliosis of the spine is present. Percussion, there is impaired node in the left clavicular, supraclavicular, infraclavicular, axillary.
The left side, clavicular.
Supraclavicular.
Chronic systemness.
Chronic systemness is also impaired on the
left side.
Left side. Tidal percussion is positive. Top space tympanic node is heard. Left hard border corresponds to the apex, and right hard border dullness corresponds to the right sternal margin. On auscultation, there is decreased breath sounds heard in the supraclavicular, infraclavicular, axillary, and suprascapular area on the left side. Vocal resonance is increased on supraclavicular, infraclavicular, axillary. So it's decreased, sir. Vesicular breath sounds. It would not make out, sir. No, sir. Decreased, sir. Vocal resonance is increased in supraclavicular, infraclavicular, axillary, and suprascapular area. Coarse end crepitations heard in left suprascapular, axillary, supraclavicular, infraclavicular area. Also heard in left infraaxillary and infrascapular area. Egophony, bronchophony, whispering, petrology heard in left suprascapular, supraclavicular, infraclavicular, and axillary area.
Are you sure?
Yes, it's heard.
It's very difficult to believe because the patient doesn't have a bronchial breathing. These things will go together with the bronchial breathing. This is widespread area. So maybe it's increased, but bronchophony, egophony, and this thing.
So anatomy, it is involving the left upper lobe. Fibrocavity disease with superimposed consolidation. Post-TB sequelae, probably secondary infection.
Okay. So you are telling it's a left upper lobe fibrosis with cavity with consolidation.
Yes.
You are putting three pathology together. Very difficult to believe. Why?
So because
not even patient is breathless, patient is not on oxygen. Sorry. there is a bronchial breathing there, the anterior part. Okay, definitely there is a bronchial breathing, and that area there is a increased vocal function, even in the back. Even in the left axilla there is a bronchial. So these two areas there is a bronchial breathing. What type of bronchial breathing? Is it tubular or cavernous?
So actually, when I had auscultated her, sir, there was absence, sir, because
That is a bronchial breathing is there. Okay, so the question is, so left upper lobe signs are there, fibrosis or volume loss. Okay, volume loss, there is a left-sided trachea, impaired note, movements are decreased. This all suggested left upper lobe fibrosis. Second thing is there a cavity disease? What cavity disease? What signs will be?
So,
what are the classical signs of cavity?
So there will be increase in vocal resonance and vocal femininity.
Classical sign.
And
cavernous bronchial breathing. And one more important test is a post-tussive suction. If you want to choose one sign, it's a post-tussive suction you should get. So classically, no crepitation, tubular bronchial breathing is not tubular bronchial breathing here. It's a some bronchial breathing like this thing is there. If it is because she is wearing mask, I also little scared to this. Okay. Post-tussive suction, you have to see if there is a bronchial breathing. Okay. Consolidation. If the patient has got a consolidation, according to left upper lobe consolidation, what is the cause of left upper lobe consolidation?
So because of secondary infections, sir, because of the structural
Again,
damage.
consolidation is more common in the upper lobe due to either staphylococcus, Klebsiella, fungal pneumonia, or tuberculosis. So, patient with the underlying lung disease, patient will be much more. And again, you told reactive air disease. There is no wrong here.
No, sir.
Okay. There is a. What are the signs of cavity? So there is a bronchial breathing. Again, it is not very classical cavernous bronchial breathing. Not even a classical consolidation like picture, because there definitely bronchophonia, egophonia is well heard. No, VFR is increased. So there must be some pathology there. So how do you say it's a fibrosis, not collapse?
So in collapse, there will be absent breath sounds, sir.
Yeah. Fibrosis, breath sounds will be?
It's reduced, sir.
Reduced, okay.
Second thing is that vocal fremitus and vocal resonance will also be reduced in case of collapse, sir, whereas there will be increase in case of fibrocavity.
Collapse, all the things will be decreased. Then percussion?
Percussion, there will be an impaired note.
Percussion in a fibrosis is a regenerative process. It will not be impaired everywhere same. Collapse is a complete this thing. It is a uniform dullness. Again, breath sounds can be absent or partial collapse. You may get a bronchial breathing loss because of the disturbance. Okay. So, secondary infection and consolidation is not very difficult to agree here. What is the sign of classical sign of fibrosis?
Sir, because of the pulled trachea, volume loss features.
Volume loss feature is there.
Yes, sir.
Can it be everything is due to only fibrosis?
Sir, but bronchophony, egophony, whispering cannot be.
Increased vocal resonance is there when it becomes solidified lung. If there is a pulled trachea or fibrous lung, you may get a bronchial breathing. It's like a solid transmitting. So usually it will be classical tubular bronchial breathing, but here it's not very classical. So again, sign of consolidation, crepitation. Is there so much crepitation? I didn't hear much crepitation. So classically crepitations are very much prominent and impaired notice this thing. So is it just a part of some amount of collapse consolidation or fibrosis? Fibrosis causing all those things. Involving left upper lobe, superficial, likely to secondary infection. Infection is definitely there. She has got a fever. Okay. So how do you confirm that?
So first we would like to go for routine investigation, sir. Her CBC is showing HP of 10.5, total count of 9,000, platelet of 3.
So unlikely to be any severe bacterial infection. ESR is
85. RFT is normal, LFT is also normal. This is her chest X-ray, sir.
Yeah.
Now,
what is there in
in the left side, there is homogeneous mass seen in the left upper lobe.
Homogeneous mass, or what you say? Non-homogeneous opacity. Okay, with
so with pulled trachea towards the left side.
Pulled trachea, that's what it is. Pulled trachea.
Yes.
And is it a fibrosis or consolidation?
There's a fibrocavity below that.
There is a cavity. there is a small cavity visible.
Yes.
Okay, but I don't know whether that cavity is causing so much this thing. It's more of a fibrosis, fibrothorax. But we say whole lung is involved, it's called fibrothorax. It may be just a bronchial breathing is due to fibrosis. And the fibrosis will cause linear streak this thing. Okay. Is there CT scan? Is there active tuberculosis?
Sir, they have, she's not able to.
When you see X-ray, can you say active tuberculosis? Cavity, if it is there, strongly suggests, but this is a small cavity. You have to consider active tuberculosis. What are the other signs? Fluffy shadow. Fibrosis is a part of chronic. Fluffy shadows are seen because there are some shadows are seen in both legs. Is there a this thing? Then third thing is a effusion pneumothorax is there along with that. You have to suspect active tuberculosis. Again, one more unusual feature is that most of the time tuberculosis affects the right upper lobe. Many of the patients who have developed left-sided tuberculosis, they have developed fibrothorax, which we have noticed. I don't know what is the mechanism or something. Tuberculosis affects the right side. Those who got left side chronic sequelae, fibrothorax is known. It's something like a fibrothorax part of that. Next.
This is a ECG, sir. Normal sinus visible.
I think, okay. CT scan?
Sir, CT was done in December, sir. It was not done during the submission.
No, that time there was no symptoms.
That time when she had got admitted, she had fever with cough with expectoration, sir. So they had got CT done in December, which showed features of calcific fibrosis with tractional cystic, varicoid and cavitatory bronchiectasis and wall thickening with volume loss of left lung upper lobe as described. Multiple solid density nodules and centrilobular nodules with few of them showing cavitation and
The centrinodular nodules is suggestive of active tuberculosis. I don't know whether the bronchoscopy has been done to rule out active tuberculosis. Okay.
So likely active infective etiology.
That's what I should use. What is it called? Tree in the bud appearance, not a classification. Endobronchial spread. So when you got strongly suggest active tuberculosis, rule out secondary infection.
That's also no other investigations.
So this case is again when you got a cavity. So one of the most important symptoms is a hemoptysis. When you get a fibrosis, again you will have a movement of the trachea. Trachea will be shifted. Impaired note because it's a fibrosis is a regenerative process. It will not be full same. Collapse will be diffuse process. Both lung will be involved. So here it is a streaking. Some areas, if you see here, some areas more dull than the other. So it's a sequel of a old tuberculosis. Whether she has got active tuberculosis, only you have to do endoscopy, bronchoscopy, and see. And she doesn't appear to be in active bacterial infection. She is not hypoxemic or not febrile. The brain is there. Okay. So, is it a fibrosis collapse? You should know by volume loss. Acute process is collapse. Patient will be more breathless. Long-standing process is fibrosis. Long-standing breathless. Retraction will be there, and the impaired note. Again, fibrosis usually doesn't cause bronchial breathing, but bronchial breathing can occur if there is a diffuse extensive fibrosis or pull trachea syndrome. When you get a pull trachea syndrome, you will get a bronchial breathing here, but she has got a bronchial breathing even in the accident. So there is extensive fibrosis. So what we say is related to fibrothorax, but lower part of the lung is not involved. So it's a is there an active infection or is just a post-tuberculosis sequel? Does she have a bronchiectasis? No hemoptysis. So no hemoptysis. So suggestions of active tuberculosis, weight loss, fever is not good. But still, in that CT scan show which we cannot make out by clinically, nodular shadows or opacities, we have to do the bronchoscopy. Thank you. So I'm getting late, so I will leave. Thank you for all the Manipal we do and DAP this year we are planning on June 15th. It will be 2 days. We will have a 2 clinical neurology case. Professor Chandra from our previous day, you must have heard about her name. Okay. Wait. Yeah. So she is coming. Cardiology from Prabhav will be coming. So then we will have all the professors from Mysore Bangalore say we have, and 2 neurology, 2 cardiology case, and 1 respiratory and abdominal case, and ECG. Our professor Bal Subramanian ECG, ABG. So if those who are interested, can send the thing to So thank you. I hope I could do justice because I could not prepare much. Thank you.
That's all the important points.
I want to just tell that medicine is not small subject. It's a very vast. Earlier days when we used to read, we had to read Adam's neurology, Brownward's cardiology, Williams this thing, endocrinology like that. Nowadays, if I have got one iPad, I have got all the books of clinical medicine in one this thing, and information revolution is there. So whatever you want now, therapy you got up to date. If you want any question, chat GPT. But what has happened is that direct interaction with the patient, seeing the patient, which you never make that experiences. Okay, thank you. Whatever you want to find, you can find. But what you see in the patient, it will not be there in any information from the net.
So that is the summary of these kind of programs. You get lots of information from textbooks, but to apply it critically in analyzing the patient problems is matters there, the experience of the treating physician. So we should look forward to such situations where you learn in the bedside of secrets in medicine in making a clinical diagnosis. So this has been the first experimentation of its kind with respect to the masters in medicine classes. So you can give your honest feedback to see how the situation can be made better in the coming classes. As I said in the morning, it is being planned to conduct this kind of session once in 4 months by a outside professor in a reputed institution, if not as reputed as KMC Manipal. So we'll try make best efforts and we'll utilize the services of Professor Prabhu in getting the resource faculty who is very appropriate for the situation. So with these viewers, again, I express on the behalf of the Department of Medicine postgraduate staff our sincere thanks and gratitude to Dr. Mukhyaprana Prabhu for having come all along from the place of Manipal to Mysuru and spent hours with you. So it's not an easy job. So it reflects his commitment to the student community. As he also said, Mysore he considers second home. That also might have played a significant role in his acceptance of our invitation. So again, I thank him wholeheartedly for having been with us on this occasion. And as a token of gratitude, it's our pleasure and privilege to hand over a memento from the Department of Medicine. I request also, I take this up to thank again Dr. Shashidhar, who was actively involved in making this platform going from local to global level. Understood? So he was very happy to get involved. It is because of his efforts that what started as a small initiative in my mind became a very attractive proposition, which has been appreciated by faculty in different places. Again, I take this opportunity to thank Dr. Shashidhar on behalf of Department of Medicine for the same. Also, I thank Dr. Prasad, who has been a coordinator for the program. He has been here from morning, coordinating all the required efforts. So I take this opportunity to hand over the memento to Dr. Mukhyaprana Prabhu as a token of gratitude.
Okay, sir.
Thank you. Thank you everyone for tolerating me for so many hours.
Prabhu.